Call the meeting to order. Start with agenda item number 1, the minutes. Included in your packets are copies of the minutes from the September 20th meeting of the Commission. If there are no changes or corrections, I'll entertain a motion for approval. Second. Any discussion? All in favor? Aye.
Aye.
Minutes are approved. And which commissioner's on the phone?
Commissioner Metz.
Okay. Welcome.
Thank you.
Agenda item number 2 is the update of activities. You've received the written updates from the centers. Commissioners, do you have any questions on those written updates? And Ben, do you or any center directors have any questions or updates to share?
First off, we are replacing our microphones over the next couple months, so hopefully the ability to communicate will improve, but that's not my main update. You may have noticed in an earlier agenda that we had planned to bring before you action on the freestanding medical facility regulations. We received some comment from the Department of Legislative Services staff that are staff to the administrative and executive regulatory committee in the legislature regarding a couple issues, most specifically the Commission's authority to, as part of a conversion of a acute care hospital, the ability of that hospital to simultaneously migrate surgical capacity to a freestanding medical facility campus. The Legislative Services maintained the statute did not give MHCC authority to approve surgical capacity or OHCQ the ability to license surgical capacity outside of a CON process. We will be talking with staff at the effective agencies, OHCQ and CLS, as well as meeting with stakeholders to discuss possible changes in the proposed regulations with the intent to bring them back to you in November. The second item I wanted to update you is some of you who've been with us for a number of years know that we have a responsibility to assess insurance mandates that were considered but not passed by the General Assembly in a previous session. With the passage of the ACA, that activity diminished, but in the 2016 session of the legislature, there were several mandate bills that did not pass. We received a request from Senate Finance and Health and Government Operations in the House to conduct mandate assessments, one being on the coverage of digital tomosynthesis for routine mammography. A second was coverage of lymphedema treatment, evaluation, and diagnosis. A third was coverage of long-term antibiotic treatment for treatment of Lyme's disease. We've determined that we will have to provide estimates of the social, medical, and financial costs of the first two bills. We think they likely will appear in the 2017 session. So we've sought an actuarial firm assistance in conducting these assessments. And I think the Lyme's disease legislation, we will respond with a letter to the committee pointing out the limited medical evidence for use of antibiotics and the long-term antibiotic treatment for Lyme's disease. I would note on that piece of that particular mandate, it did pass in Massachusetts over Governor Baker's veto, but I think that rather than spend scarce MHCC resources, on an assessment that we put together our best assessment of the medical evidence for that particular protocol, and leave it at that, along with our recommendations. I also wanted to talk very briefly about our collaborative with the network of regional health initiatives that we have our award that was given to MHCC. It brings us into a collaborative effort with 10 other regions and states around the country in terms of bringing and aligning APCD reporting for measuring costs, the total cost of care specifically. We have completed most of that work, particularly as it relates to using the total cost of care metric to assist primary care practices. We had a very productive meeting with the 3 pilot practices earlier this week, and we'll be submitting our report to ENRI later this month. We also have been told by ENRI that they, as part of their work, they are funded through the Robert Wood Johnson Foundation. They will be issuing a report on a comparative analysis of APCDs and the ability to use these data tools to measure total cost of care, as well as to compare the performance of different regions using these data systems. What I can, the information has not been released. We've seen some early drafts, but I would say that Maryland's performance under this subset of regions in the country looked very good. We point to some of the work, and this is focused only on the privately insured, not the Medicare population or the Medicaid population, but it does seem as though initiatives here in the state, such as patient-centered medical homes, perhaps the global budget efforts that the state has embarked on, seem to be bearing some impact in the private market. I'll certainly share with you all of that information as soon as it's released by RWJ. Also related to cost and transparency reporting, I would note that we have, as part of our grant with the federal government through SOCIO, begun to work on a cost transparency initiative using an episodes of care grouper developed by Healthcare Cost Initiative Institute. You've seen some presentations by the head of that group, Francois Debrandis, and we are sharing with you an illustration of how we propose to roll forward. That's draft 1 of a public engagement effort that focuses on raising awareness in the public on cost variations on common episodes of care here in the state, including several orthopedic procedures, as well as a number of chronic care conditions that are treated in ambulatory settings. The important hook to note here is I think we realize that quality and cost reporting has been around for a while, but through this effort, we're going to be using some innovative handles, if you will, to engage the public. You'll note here in that presentation, the link is where the cost, and it focuses not only on raising awareness among consumers who will encounter those episodes, but also a broader range of the public who is indirectly affected by significant variations in cost because of the impact they have on healthcare premiums. I expect that version 2 of that will be available shortly, and we will be hosting a webinar in which I would encourage commissioners to participate to understand the directions we're going. We're still a ways away from making anything public, but we're trying to move forward even in this development phase in a transparent manner. That concludes my update. I'll be happy to answer any questions.
One in your updates, the written updates, you also mentioned about the Department of Labor seems to be tentatively moving forward on the the self-funded plans. Is there any notion of where that might be happening, or how quickly?
You will not be heard otherwise.
So short answer, don't hold your breath. This is going to take a while. I think they had some time and they set some deadlines, and the various state all-payer claims databases and other entities that are working together to do the submissions that collaborated, which was a feat in and of itself. You know, like 2-hour meetings every week so that they could come up with a common data layout. And so I think there's a deadline for submission, and then the Department of Labor is going to have some time to review it. And so nothing's really decided, but the very fact that we were able to all get together and come up with a plan and meet the deadline for submission, which is actually in November. Okay.
Any feel for whether there's a major opposition from the self-funded plans at this point?
No, actually, I think most of the dialogue has been between the data vendors and the people who get their data from, which is principally carriers and third-party administrators, and not really any of the employers who are covered from ERISA.
And we wouldn't expect anything until the next administration, probably, unless they're crazy.
Yeah, no, I don't see any turnaround before January. Yeah. I have 2 items to update you on. The first is I'd like to introduce the newest member of our Center for Quality Measurement and Reporting team, Courtney Carta. Here's Courtney. Courtney will serve as our program manager, focusing on healthcare-associated infections in our Hospital Quality Initiatives Division. Prior to coming to the Commission, Courtney worked as a senior-level researcher with the National Institutes of Health, where she worked on a study of diversity in healthcare and physician specialist workforce, and with the Agency for Healthcare Research and Quality, AHRQ, on an evaluation of the HHS National Action Plan to prevent healthcare-associated infections. Courtney holds a master's in public health and epidemiology from the University of South Carolina. So I'd like you to join me in welcoming Courtney to the Commission. The second item, I'd just like to update you on the most recent update to the website. We have, for our October update, updated the Health Benefits Plan guide with new HEDIS audit information as well as CAHPS information. Overall plan performance is similar to what it was last year and the year before. We're basically at and sometimes a little below the national performance. There are some bright spots. For example, on the about 80 HEDIS measures, Kaiser Permanente, the HMO, was a top performing plan for about 35 of the measures, and CareFirst, GHMSI, in terms of the PPO, was a high performer on 18 measures. But again, overall, our performance here in Maryland is at or below the nation. Any questions regarding that? I invite you to take a look at the website when you get a chance, so it's now available. Thank you.
Thank you. Let's move to agenda item number 3, which is State Health Plan for Organ Transplant Services chapter. If you recall, over the summer, this was brought first up by staff, and after a round of discussion at the Commission, the guidance was to delete draft regulations 0.04, which contain docking standards. The purpose of deleting the docketing standards at that time was that the majority of the Commission felt it was important to sort of reduce barriers to entry into the market for transplant, and that eliminating the docketing standards would do that. So after the chapter was approved, staff then identified several inconsistencies in the regulation that resulted resulted from elimination of the docketing requirement and one unrelated technical issue. And since these issues hadn't been discussed, we just want to bring this back to the commission at this time, consider them, and then vote whether to adopt the revised proposed regulations, which would contain the initial intent of the last vote, but adjust some of these inconsistencies. So Eileen Fleck is here to present those draft changes. Eileen?
Thank you. Good afternoon, Mr. Chair and Commissioners. So MHCC staff provided in your packets a copy of the draft proposed COMAR 102415 that has track changes showing the changes compared to the document that you would have seen at the September Commission meeting. And so I'm just going to run through that. It might be helpful to pull it out now if you want. The table of contents shows that we've deleted the certificate of need docketing rules, which was 0.04, and so that results in renumbering the regulations and the sections. Also, there was renumbering of tables because there was a table in the docketing rules. And then I have shown in this document on page 25 the docketing rules that you voted to delete. And so you can see that there is a table, the threshold volume standards, that's included in the docketing rules. And that table is also referenced in the impact standard. And so we needed to move that table, we believe, to the impact standard. I guess just to remind everyone in terms of the docketing rules, so by deleting those docketing rules, it's no longer the case that a new program would be able to operate for 3 years without facing competition from other new programs. And then also a new organ transplant program can be considered even if existing programs are not at or above the threshold volume standards. And so the threshold volume standards are incorporated into the impact standard. So that begins at the bottom of page 30. And so without any changes in terms of how the impact standard read before, it would read, a new organ transplant service or relocation of an organ transplant service shall not interfere with the ability of existing transplant services of the same organ type to maintain at least the annual threshold case volumes required by this chapter. So it's pretty clear that it was referencing the threshold volumes that were included in the chapter. And what we're proposing, which is shown, it continues on page 31 with underlining for the new text, we're basically proposing that we refer to the 3-year average annual threshold case volumes because the table reference had that as the title of the table. And then also, it wasn't referenced, so it wasn't referencing a single year, which is what the text in the impact standard has. And then also, we thought that it would be useful to specify the source of the data for the standard, and so that's UNOS. So the new standard, I'll just read it for everyone, would read, a new organ transplant service or relocation of an organ transplant service shall not interfere with the ability of transplant services of the same organ type to maintain at least the 3-year average annual threshold case volumes required by this chapter as measured by the most recent data available through UNOS. So we do think these changes are minor. We did still want to come back to you because we hadn't talked about them or realized that we would need to make some small adjustments. There were not any objections to those standards in terms of the informal comment process or by Johns Hopkins Medicine, which had specifically recommended deleting the docketing standards in a letter that was sent to you in September. And so we also don't believe that the standard blocks approval of a new program if an existing program is below the threshold volume, which I think had been a concern with the docketing rules, and that was an issue that was raised. So we don't see this as just the docketing rules in a different place or part of the docketing rules in a different place. That's not how we see this. And so those are the key changes. The table, we've moved it to the end of the impact standard, so that's on page 32. It's exactly the same table. And then the last change that I'll mention is on page 36, which is the definitions. There's a definition mentioned for a teaching, included for teaching hospital, and that's not referenced at all. So obviously it doesn't make sense to include a definition for a term that we're not using in the chapter. So those are all of the changes, and that concludes my presentation. I'd be happy to answer any questions.
Do I have a motion to adopt the revised organ transplant services chapter as proposed permanent regulation? Move the second. Any questions for?
Hi.
Hi.
Back again. So anyway, just wondering, in terms of this, I'm just a little confused in terms of this interaction between the proposed language you've got here and the dropping of the docking standards. Because when I first read the proposed modification, it sounded like that barrier was back in place, just in a different spot in the reg. And so I just need a clarification of there's not the same kind of restraint of new entrants. We're setting these we're setting levels. We're saying, we're now doing it a better way with a 3-year average rather than a 1-year kind of hit to the system, however you want to think of it, but a statistically more volatile way of doing it. But how is this? Is this still allowing a new transplant center to open without having to wait for the one previous to have their 3-year protective period?
The 3 years is definitely out of the regulations. That was only in the docking rule. So there's no 3-year protected window for a new program. That was only in the docking rule. So that's
okay.
out.
And so what do these thresholds then do for the regulation at this point if it's not that barrier to entry?
Well, it does provide some guidance to applicants in terms of what the expectations are and in terms of maybe how to look at the impact on other programs and what might be relevant.
So in your professional advice, you would not think of this as having a chilling effect on a new program thinking of entering into the Maryland market?
No, I don't think it should be. I think, I tried to explain at the last meeting also that in terms of the actual volumes that were set, that, given the existing programs and the types of volumes that they're doing, like we didn't see it as a particularly high bar given the current and sometimes the very lengthy history we have in terms of the volumes of the existing program. But like I said, it is different. It's not this strict bar to even considering the program.
Okay. Thank you.
Other questions? Move to a vote. All in favor? Aye. Any opposed?
Aye.
Aye. Any abstentions or opposition? If not, it's approved.
Thanks.
Let's move on to agenda item number 4, which is the certificate of need for Dimensions Health Corporation, doing business as Prince George's Hospital Center and Mount Washington Pediatric Hospital. Commissioner Bob Moffett served as the reviewer of the contested certificate of need application by Dimensions Health Corporation and the Mount Washington Pediatric Hospital to relocate and replace Prince George's Hospital Center, creating the Prince George's Regional Medical Center in Atlanta. None of the interested parties filed exceptions. In fact, on October 7th, interested party Anne Arundel Medical Center sent a letter endorsing the adoption of the recommended decision by the full commission. I ask Commissioner Moffett to address the commission regarding his recommended decision.
Thank you very much, Mr. Chairman and fellow commissioners. I have examined this case for over 17 months. And after conducting a site visit at the existing hospital and the proposed site, and considering voluminous elements of the record in this review, I strongly recommend that the Commission approve this application for a certificate of need. I found that the proposed project is consistent with the certificate of need review criteria and all of the applicable standards in the state health plan for facilities and services. I want to remind the commissioners of a vitally important fact about our role in dealing with certificate of need. One of the basic purposes of Maryland's certificate of need law is to restrain excess capacity, including the excess construction of hospital and other regulated healthcare facilities. So the law is designed to restrain excessive supply, allow for coordinated healthcare planning to meet the needs of the state, and thus to control or reduce Maryland's overall healthcare cost. That is the duty of the Commission, to enforce the law and to apply the regulatory standards to achieve that goal. I think that's vitally important to always keep in mind when we're dealing with something like this. In this particular case, in their 2015 application, the applicants proposed an estimated total project cost of $651 million. The Commission had never previously considered an application for a project of this amount of capital funding from Maryland taxpayers, nor such a large proportion of public funding as a component of the total capital funding. I concluded nonetheless that there was indeed a clear and compelling need for a replacement hospital in Prince George's County, and that its proposed location in Largo was an excellent choice. I also determined during the course of this review that the most serious need in the county was the provision of a robust primary and ambulatory care network to serve the pressing needs of the people of the county and to improve the health status of those who are suffering, particularly from chronic illness. The January 2015 submission was compliant with over 50 regulatory standards. However, the most significant problem was the financial feasibility of this historically large capital project. And I determined at the time that, as presented, this would jeopardize the proposed replacement hospital's future financial viability. I concluded, therefore, that the cost of the proposed project, as it had been presented, and based on a comparison of other hospitals in the region, was unwarranted because of excessive space and service capacity. I asked on May 17th for the applicants to join us in a project status conference, and there I clarified that my recommendations did not entail any substantive changes in the replacement hospital's lines of service, but primarily involved reductions in cost and size. I explained that the project was out of proportion to the need, as we had determined by our own evaluations of volume and discharge patterns and the Commission's own bed need. I found that the project's relatively high cost when compared with similar hospital projects required reconsideration of its size and its scope. I also concluded that the overall investment was too heavily weighted to hospital facilities and that more resources should be invested in primary care development. The strengthening of primary and ambulatory care in Prince George's County will not only meet the most pressing needs of the people in that county, and they have expressed this in surveys on this issue, but because of the increased referrals from physicians and other medical professionals, I determined this would be also vital to the long-term viability of a new hospital. So a new and robust primary and ambulatory care network was essential, in my view, to the overall long-term success of this major project. On August 31st of this year, the applicants modified their application and complied with my specific recommendations concerning the cost and size of the project. The applicants reduced the total project cost from $639 million to $543 million, reduced the total construction cost from roughly $285 million to $225 million, and reduced the total square footage of the project. They also reduced the total number of beds from 216 to 205. This was a slight variation from my recommendation, which was 202. This was based on the applicant's review of the specific bed needs, including their pediatric needs, and I thought that their presentation on that was reasonable and acceptable. At the status conference, I also asked applicants to detail measures that they would undertake to improve operational efficiencies with the hospital. I'm happy to report the applicants have complied with my request and have outlined a detailed set of measures designed to increase operational efficiency. I consulted with the Health Services Cost Review Commission on this matter, and I asked them for their assessment. And on September 21st, 2016, they sent me a memorandum precisely on this issue, along with others, and I'll just read it here. It says, quote, "In summary, we believe that the performance improvements identified by PGHC and their certificate of need modification are achievable. And furthermore, we believe that the hospital will exceed the savings estimated from performance improvements, which will have a positive impact on the projected income statement." I also, of course, emphasized on May 17th my deep interest in improving the primary and ambulatory care networks in Prince George's County, which, again, was not only essential to bettering the health of the people in the county, but also, of course, would strengthen the long-term financial viability of the hospital. The applicants have complied with my request to give me a more detailed view of how they would actually improve those efficiencies, and they've done it in exhaustive detail, how they would improve and expand their primary and ambulatory care system, which comes to the issue of exactly going forward how this program will proceed. I have to remind the Commission that it is in fact common knowledge that the Prince George's County Hospital Center has long endured a series of serious financial and managerial problems. These problems have been well documented in various reports and analyses. They have been widely discussed in the general media and the press. To their credit, the leadership has made repeated attempts to resolve these problems over the years, but even with their best efforts, they have fallen short of their own expectations. At the same time, the institution has been on the receiving end of rather large and continuous infusions of taxpayer subsidies from both state and county officials. Ladies and gentlemen, the long-term financial viability of this project is ultimately going to be dependent upon sound management. A strong and effective management will help secure efficient delivery of the high-quality healthcare services and cost-effective care that the residents of the county clearly deserve, but it will also establish an institution on a firm and permanent financial footing, and finally bring to an end the dependence of the institution on an expensive diet of taxpayer subsidies. Indeed, for their part, the applicants themselves have declared formally their desire to be free of this unhappy dependence. At the status conference, I asked the applicants to provide an account of the proposed management and governance of the new hospital. Once again, the applicants have complied with my request. Under an August 30th, 2016 memorandum of understanding provided with the modified application, UMMS will become the sole corporate member and assume governance of Dimensions shortly after the Commission approves the CON for the new hospital. I asked the Health Services Cost Review Commission to give me an assessment of the funding of the new project. I'm happy to report that they say that the funding of the new hospital appears appropriate, but they did note that the applicants will still need to resort to some short-term borrowing for the hospital's early operation. Which brings us to another issue, and that is that over the next few years, the hospital's rates may still not be competitive. In their September 21st, 2016 response to my inquiries, HSCRC staff noted that a review of the current performance shows that PGHC per capita charges are still 12% higher than its peer hospitals. However, I want to remind the commissioners that they have added a critical qualification. The staff notes that its analysis incorporates the crucial fact that PGHC serves a disproportionately larger share of high-cost patients through its trauma center, as well as a significantly larger pool of indigent patients, and these factors contribute to the higher rates. Over the next few years, HSCRC says that unless there's a change, there could be even higher rates. The HSCRC staff then warns that the hospital's rate structure would have to be subject to the HSCRC prescribed efficiency measures. Commissioners, you all know, of course, that healthcare rate projections, just like healthcare cost projections, are plagued with numerous uncertainties, such as the payer mix, the ability to retain the hospital's traditional patient base, the ability to attract new patients and increase volume, the ability of the new primary and ambulatory care networks to be a feeder for the hospital to increase its volume, the ability of the hospital to develop a reputation, a serious reputation for delivering high-quality care in the region, as well as securing control over the delivery of care to effect economic efficiencies economic efficiencies, I remind the Commission that the applicants have already outlined in great detail. The University of Maryland Medical System, I am absolutely certain, will do their part to improve the performance of the hospital. They have an excellent reputation, and I believe that they will deliver on this one. Fellow Commissioners, the people of Prince George's County really need and deserve a strong, revitalized healthcare system. And a modern hospital is absolutely crucial, as I said before, in that equation. I also noted in the past for the Commission that this decision takes on a special gravity because of the very large investment in this project that is being undertaken by Maryland taxpayers. And for that reason, primarily for that reason, I issued a recommendation that would reduce the overall size and cost of the project to help bring it into line with comparable projects and lay the groundwork for a very strong, permanent financial basis for the new regional medical center. With these changes in the modified application, the Commission can really help the people of Prince George's County secure the goals that the applicants have outlined, goals that we all share, and do so at a lower cost than the original application. Returning the modifications to that application, the modifications I recommended, the applicant stated in their most recent communication, quote, Dimensions and the University of Maryland Medical System are confident that the reviewers' recommendations compromise neither their ability to serve the healthcare needs of Prince George's County nor the transformational quality of the proposed project. Commissioners, by allowing this project to go forward, we are going to well serve the people of Prince George's County as well as the people of Maryland and demonstrate to them that we are sound stewards of its success and sound stewards of their taxpayers' dollars. I ask you to support my recommendation. Thank you.
Thank you, Bob. I move that the Commission adopt Commissioner Moffitt's recommended decision as the decision of the Commission and award a certificate of need to Dimensions Health Corporation and Mount Washington Pediatric Hospital to build a replacement hospital known as Prince George's Medical Center as detailed in the recommended decision. Do I have a motion? Second? Second. Okay. And then we have many people here today from Dimensions, Mount Washington Pediatric Hospital, the University of Maryland Medical System, KPMG, Berkeley Research Group, Wilmot Spence, and others. I would ask Tom Dame, lead counsel for Dimensions in the Review, to introduce representatives who are here today. And I understand that Neil Moore, President and CEO of Dimensions, Judge Philip Nichols, Chairman of the Dimensions Board of Directors, and John Ashworth, Senior Vice President of Network Development at UMS, would like to address the Commission briefly and may do so after Mr. Dame introduces the representatives who are here.
Thank you, Chairman Tenio. Commissioners, as Chairman Tenio indicated, we have a number of people here, and I'd like to introduce them. We have a large number because it's such an important project. So we have members from both Dimensions, from Mount Washington Pediatric Hospital, from the University of Maryland Medical System, and some of the consultants who work on this project. I'll start with Dimensions Healthcare System. Judge Philip Nichols is Chairman of the Board of Directors. Neil Moore, President and CEO. Terry Perkins, Executive Vice President and Chief Operating Officer. Dr. Carnell Cooper, Chief Medical Officer and Vice President of Medical Affairs. Carla Jean-Baptiste, Senior Vice President and General Counsel. Jeff Johnson, Senior Vice President for Strategic Planning and Business Development. Jeff serves as the team leader for the CON project. From Mount Washington Pediatric Hospital, Mary Miller, Chief Financial Officer. From the University of Maryland Medical System, John Ashworth, Senior Vice President for Network Development. Mark Wasserman, Senior Vice President, External Affairs. Daryl Mealy, Vice President, Construction and Facilities Planning. Karen Lancaster, Vice President, Media Relations and Corporate Communications. And from the other project team member group, Andy Solberg, Healthcare Consultant, CON Matters. Craig Wheelis of KPMG. Aaron Foreman, KPMG. Craig Moskowitz from the architectural firm of Wilman Sand, back there. Terry Haver, cardiovascular services consultant. Josh Repack, Berkeley Research Group, and my colleague at Gallagher, Billius & Jones, Ella Aiken. We're all happy to be here today with you commissioners in this significant step toward the realization of Prince George's Regional Medical Center. I'd like to thank the commissioners and especially Commissioner Moffitt for his work in this case and the commission staff. Thank you.
Tom? Mr. Moore, Judge Nichols, and Mr. Ashford may now address the commission.
Good afternoon, Mr. Chairman and Commissioners. I don't want to talk you out of doing what I think you're about to do here, because it's about the best thing to happen in the last 50 years in Prince George's County, Maryland. But I do need to thank you on behalf of the Board of Directors of our system for what I think you're about to do. Our vision was to develop a viable and vibrant regional healthcare delivery system composed of a new academic affiliated regional medical center supported by specialty and primary care professionals, as well as community health programs designed to impact the health status of Prince George's County residents. I need to tell you that in the mid-1960s, when Gladys Noon Spellman was my predecessor as chairman of the board, the then board said, Gladys, you need to go talk to the University of Maryland. We have been talking ever since. That long discussion apparently is going to come close to fruition fairly soon, I do believe. We believe our partnership with the University of Maryland Medical System will result in enhanced and expanded clinical programs. We also believe our partnership will strengthen our graduate medical education programs, which will serve as a catalyst to attract, recruit, and retain healthcare professionals that we need so much in Prince George's County, Maryland, and all of Southern Maryland. The University of Maryland School of Public Health determined we were short 61 primary care physicians yesterday, and it continues, and half that in dentists. And part of the strategy is becoming part of a large teaching organization with the reputation the university has. That is the strength of what's going to be our success in the end. We've worked closely with the executive leadership of our organization, along with the board, on this vision that we have, and it's a new hospital, and it's more than a hospital, it's a teaching hospital that everyone will have confidence in and want to go to. And part of that is we train physicians, so you develop an even higher level of confidence in what goes on in that facility. We're excited about the future. And today represents, as I said, probably the most significant thing to happen in healthcare in the last 50 years in our county. I'm very grateful to be here. This is really a nice place to work, it looks like to me, having never been here before. But thank you for being so nice to me. I appreciate it.
Good afternoon, Dr. Tanya, Executive Director Stephan, Commissioner Moffitt, and members of the Commission. Thank you for creating another great day in Prince George's County in the Southern Maryland region. As a healthcare professional for more than 20 years, I think this is one of the biggest achievements within Prince George's County to provide good healthcare services throughout the county and Southern Maryland region. As President and CEO of Dimensions Healthcare System, I do want to thank all the members for their support, including the Commission staff that have worked tirelessly to get us to this point. I would also like to thank those who participated in our internal organization as well, working on the CON. That includes KPMG, who you just recognized here, the Berkeley Group, Wilman Sands, ALS Healthcare Consulting Services, the law firm of Gallagher, Billius & Jones, as well as the facility department at the University of Maryland Medical System. However, this milestone would not have happened without the support of our coalition members, including the state of Maryland, Prince George's County government, the University of Maryland Medical System, University System of Maryland, and Dimensions Board of Directors. I'm happy to have the chairman here with us today. In 2011, the partnership began, initiating a healthcare planning process with the objective of transforming our healthcare system with the overarching goal of improving health status of residents of Prince George's County and the Southern Maryland region. The approach we are taking was based on findings and conclusions reached by the University of Maryland School of Public Health Impact Studies that recommended some very specific things. One, to improve access to community-based provider care. Two, to establish population health practices to manage patient health and reduce the cost of care. And three, to develop an academic-affiliated new regional medical center to replace Prince George's Hospital Center. As Judge Nichols stated, this is a transformation for the healthcare within Prince George's County and Southern Maryland region. This is something that we embarked on and we continue to work towards. I thank you for allowing us on this journey in improving the healthcare quality and improving the healthcare indices within Prince George's County and Southern Maryland region. Thank you.
Senior Vice President, Medical System, and Associate Dean of the University of School of Medicine. I've testified a lot of places. I know when not to keep speaking. And so I just am up here to say thank you to all of you all. We definitely want the summary that you just read off, Commissioner Moffitt. It, I think, really embodies a lot of what we have all been through and where we wanted to go. We thank you very much for that. We thank all the commissioners for what they've done. Ben has seen me around this project for I don't know how long, and we did get it done before I retired, and so thank you all very much. But we really appreciate everything that you all have done. The journey is really just beginning, though. Obviously, the question of putting in place all the things that Commissioner Moffitt stated a few minutes ago, the medical system is ready, and we know there's a lot of challenges ahead. We have partners here that we've created over these years that will help us get through those challenges, and we have a high level of confidence we'll get there. So thank you all very, very much.
Thank you very much. We will move on to any questions or comments from the commission? We'll just sort of go in clockwise order. Yeah.
Thank you, Mr. Chairman. Get this in the right position. I just wanted to thank everyone who came today from the community and from the medical and healthcare community to support the project, because I know you'll be standing beside those who are going to make this a success. And we're very happy to work with you. Many years ago, I worked as a nurse in Prince George's County. I'm with you. Thank you.
I just wanted to thank Commissioner Moffitt, because I know that's a lot of work parsing through all of that, and the decision to me was very clear and very well laid out.
Just a couple of questions. One is, I see in the completed hospital, you have one pediatric bed, yet you have a pediatric specialty hospital within the same campus. Why do you need a pediatric bed in the one facility, yet you have a pediatric hospital on the same campus? Number two, I see on page 1, it says that Dimension is the owner and operator of PGHC, yet on page 5 it says that Dimension will be wholly owned by I'm a little confused by when is that transition, what is that transaction? Is it a monetary thing? Will own the hospital, or just govern it, run it? I'm a little confused because I have personal experience with at my facility. I'm just a little concerned about the follow through here. The other concern is the cardiac surgery program. at PGHC right now is improving, but it's still not up to par. Are there any concerns for Anne Arundel's proposed cardiac surgery unit, which will be supported by Hopkins? Wait. So there are three questions, Commissioner O'Connor, and I think we have people here to respond to each one of them. The first one had to do with the pediatric bed, and Mary Miller, who is the Chief Financial Officer of Mount Washington Pediatric Hospital, can address that question first.
Hi, thank you. Mount Washington Pediatric Hospital provides specialty care for children with complex medical and rehab needs. So, and in PG County, where we currently have that 15-bed unit, that's mostly our infant population. So that's really quite different from your typical inpatient bed. So we get the babies from that area, and then they don't have to come up to Baltimore.
Will you maintain competency of a pediatric nurse with just one bed?
No, we don't handle the one acute bed. We handle the 15 specialty beds.
Well, who's going to handle the one acute bed? And with the competency measures for one bed, can you get competent pediatric nurses for that? Sherry Perkins, who's the Chief Operating Officer of Dimensions, can address that question.
Thank you. That bed is positioned in the emergency department, proximal to pediatric observation space as well. And the competency for that care already exists within the nursing staff within the emergency department. And what we'll do over time is understand the acuity of the children that come in and when they will require observation care or when they would require a higher level inpatient stay.
So it's an observation bed or an inpatient bed?
It is an inpatient bed.
Commissioner O'Connor, your next question related to the connection between Dimensions and University of Maryland Medical System and when that might happen. And Carl John Baptiste, who's General Counsel of Dimensions, I believe is in the best position to respond to that. And John Ashworth is also here, Senior Vice President of the University of Maryland Medical System.
Good afternoon. So currently, Dimensions Health Corporation and University of Maryland Medical System Corporation are separate legal entities, but we're in the process of due diligence. And the plan, which is basically required for funding under the Prince George's Regional Medical Center Act, is for the two parties to merge, a full merger, member substitution, in legal terms, so that Dimensions Health Corporation will become a subsidiary that's wholly owned by University of Maryland Medical System Corporation. Do you have any questions?
Is there a buyout in this thing, or is it?
There's no monetary compensation as a result of the transaction. So it's a member substitution without monetary compensation being exchanged.
Thank you. Commissioner O'Connor, your third question related to the status of the cardiac surgery program at Prince George's. Dr. Carnell Cooper, Chief Medical Officer, can address that.
Good afternoon, and thank you for your question. In terms of the volume, I would agree that we are not up to par to where we want to get. However, if you look at the quality of care at our cardiac surgery program, it has currently recently received a 3-star rating, which is the highest rating by the Society of Thoracic Surgery. It is correct that we do share some concerns about another program coming in place as we grow our own program. So that's we will continue to work very hard to make sure that we provide the care necessary to increase the volume and, of course, continue the care that we can.
So I believe the requirement is 200 cases a year.
Yes, correct.
You're at 150 a year now.
Correct.
Or close to it.
Yes. And we do believe that there is an opportunity to grow, and we feel very confident that we will be able to reach that 200 plus volume.
Commissioner O'Connor, the requirement of 200 per year would be if Prince George's Hospital Center were applying today for a CON. They, of course, haven't established a program. The program has grown for this handful of cases several years ago to, as you said, in the neighborhood of 150 cases per year now. But I believe there's another benchmark for ongoing assessment. So that, yes, that will apply here until several years after the new facility opens. There's a provision in the state health plan that allows a relocated facility to meet that in the third year after. Thank you.
Any other questions or comments? If not, we'll move to a vote. All in favor? Aye. Any
Aye.
opposed? And then there's one abstention. So noted for the record. Thank you, Commissioner Hasty. You have your COA. Wanted to thank Commissioner Moffett for his and staff for their tireless work on this endeavor. We'll move to.
We're gonna get our crew out of here.
If you can, you're welcome to stay for electronic health records if you want. Okay, let's move to agenda item number 5, which is electronic health records incentive. On June 20th, in our June meeting, the Commission adopted amendments to the electronic health records incentive as proposed permanent amendments, and Angela Evat will present the final regulations after people have left.
Just give me the 6.
Mr. Chair, in this interlude,
Yes.
may I make another comment, only to pile on the expressions of appreciation that have been made towards Commissioner Moffett and the staff for this Herculean 17 months, I think it was, you mentioned the ordeal, so I can only imagine how many gigabytes of documents and countless hours and hours. So, you know, you have really represented the Commission in a sterling manner, and I think that deserves a round of applause. So thank you.
Thank you. As Commissioner Canio mentioned, the Commission had approved the proposed amendments to our EHR incentive program, so I will be very brief. As a reminder, the Maryland law enacted in 2009 requires the Commission to establish EHR incentive payments from payers. At that time, the EHR adoption rate was fairly low in the state of Maryland at about 19% compared to the national average of about 22%. The regulations went into effect in April 2009 and were amended a couple of times in 2011 as well as in 2014. Just as a reminder, this is a one-time incentive payment per payer. Eligible practices include primary care practices, and they're eligible for up to $15,000 per payer. And that payment is based off a $25 per member fee. The program sunsets in 2016. Annually, payers are required to report on the progress of implementing EHR incentive program. The impact on advancing EHR adoption and meaningful use has been moderate. All total, there's been a little over 1,600 payments made, totaling $9 million. And the average annual growth rate for program participation, we're seeing about 29%. We convened a work group made up of payers and providers in April 18 to discuss the impact of the incentives on advancing meaningful use and discuss opportunities to extend the sunset date to allow for practices to take advantage of these incentives. The work group recommended a one-time extension of about 2 years to December 2018. So during the 30-day comment period, we did not receive any comments, and staff recommends the Commission adopt the proposed amendments, which is extended the program by 2 years as final amendments for of the Commission. If adopted, it'll go into effect November 24th, 2016.
Can I get a motion to approve the final regulations of the electronic health record incentive? Second? Second, okay. Any comments or questions?
Just one quick question, and I guess I'm prejudiced towards specialists, but how come this only includes primary care physicians? How come specialists are not included in these incentive programs?
So when the incentives were first crafted, our primary care practices were significantly lower in terms of EHR adoption. What we found is that payers were willing to incentivize those primary care practices. Over the years, we've discussed potential opportunities to expand into specialist practices, which hasn't been well received thus far.
Well, is this entirely separate from the federal incentive program?
So this incentive is from payers in the state of Maryland. In order to qualify for the state incentive, a practice would have to reach the meaningful use, a test of meaningful use. So it's tied in a way. If they aren't eligible for meaningful use, they can still qualify if they receive PCMH recognition.
Well, what if we already attested to meaningful use? Would we qualify?
So a practice would qualify if they've attested to meaningful use, either on the Medicare or Medicaid side, right. And they would be able to apply to the payers for the incentive.
Until December, right?
It's extended till December 2018, if not, then 16.
Okay. Thank you.
Other questions or comments?
Yeah. And do we have I know the payers are paying for it, but do we have a notion of the cost of the 2-year extension?
Sure. We, based on the growth rate that we're seeing over the reporting period since 2011, we're estimating an extra 640 payments over the remaining, if it's extended to 18, that's about $3.5 million.
And are the payers comfortable with that?
There were.
We have at least one. We have a number of payers.
There were no written comments.
No written comment. Okay. Now we do know that, of course, if it goes into a premium, that means it goes back to the citizens of the state of Maryland. So you can think of it as the payers paying for it as a pass through. So, but at this point, the staff recommendation is that this is sort of a good return on investment.
For now, I think what we found is that there's been moderate uptake in the incentive program. What we're finding is that that providers are interested, and it is an incentive on top of what they already receive in meaningful use. Providers are also looking to the incentives under MACRA as well, and this is sort of a way to be a stepping stone to that additional.
And what is our acceptance rate or adoption rate at this point, the tested adoption rate?
In terms of 1,600 payments have been made.
Oh, no, I meant in terms of when we think of primary care practices out there, how many have already met their meaningful and attested to meaningful use? What is sort of the target population we're shooting for to close this gap and finally have everybody?
So in terms of the primary care practices that have adopted and have reached meaningful use, according to February 2016 numbers, primary care only, not all practices, 58%.
58%. So this is a nudge to hopefully get us up to 70, 80, something like that. Okay, thank you.
So if they haven't met meaningful use, that means they're getting penalized by Medicare?
So on the Medicare side, there are.
What I'm saying is that there's a lot of incentives, more incentives to get EHR on the federal side, which seemingly would qualify requirements that you have. So I'm confused about the disparity of how many people are signed up, because I think federal-wise, more people have joined on.
So that the number of 58% is only for primary care practices, which are likely to be on the Medicaid side of the meaningful use program.
So 42% of practices getting penalized right now in payment for Medicare? 2%, whatever it is? 2%.
Yeah, they won't. The program for Medicare is rolled up under MIL. So it's on the Medicaid side. And what we've not looked at this as a way to compensate practices from getting disincentivized. We've looked at this as a pathway to driving more adoption of technology for the meaningful use requirements, really as an enabler of care more broadly across the spectrum, as looking at it as trying to protect or shield a certain number of practices. There are many practices that will never adopt an EHR. It does not matter what the incentive is. So to Commissioner Grady's point, I don't think we'll ever get to 100%. 90% is probably overly ambitious, but it's going to take a lot more to drive practices in this direction. Overall, in the state, we're at 64, 65%. We option. We could layer it on the backs of this program or layer on the backs of just the forward momentum in healthcare reform that's underway in the state. But this program is helping to make a difference. It isn't the key to this, what's happening in the state. And that's part of the reason why the work group said, let's continue it for 2 more years and then just let it sunset.
Yeah, and if I give the context, I think of the dialogue that we've had at the commission, let's say, right, for the last 2 years or so as we've kind of brought this piece up. I mean, I just characterize that everybody has recognized that there was, let's just call it, modest return on investment because there had been, you know, the whole impact of the electronic health records on workflow and then what it does with others is an ongoing topic. And then, you know, a debate about how much is the state investment going to have on top of the federal. But and the commission had actually expressed some concerns about this, which has gone back to the work group over time, and you know, hence where we landed up with this sort of, let's do it for 2 more years and then sunset at that point.
Was there ever any discussion about kind of targeting the kind of specific, what we would think of as, I think of anyway, as the non-Medicare practices, who aren't really going to be under that sort of incentive system that the feds have been able to fund? Kind of the pediatricians or somebody like that who really don't have any Medicare to speak of.
So Angela mentioned that you could qualify if you're in primary care if you achieved NCQA recognition at the Patient Centered Medical Home. So we looked for some alternative strategies as well when this was conceptualized.
Thank you.
I think Medicaid was included in that too. The pediatricians have a large Medicaid.
Yeah.
Which one? So we estimate another 640 payments on top of the already 1,600, and the estimate would be 3.5 million.
Over 2 years. I don't mean to belabor this, but do they have to reach the meaningful use and a test before they get the payment? Okay. Good.
Other questions? If not, let's move to a vote. All in favor?
Aye.
Aye. Any opposed?
Aye.
1 abstention. Commissioner Flagg noted. All right.
Thank you, Commissioner.
All right. Let's move to agenda item number 6. The Northampton Manor Nursing and Rehabilitation Center has applied for a certificate of need to construct a building addition to house 66 additional comprehensive care facility beds and to renovate 2 out of the 4 existing nursing units at the facility. Kevin McDonald will present the staff recommendation.
Thank you, Chairman Tanio, and good afternoon. The applicant is Northampton Manor Nursing and Rehabilitation Center. They are owned by MHC Holdings. MHC Holdings owns 12 nursing homes in Maryland and 9 in Pennsylvania. A related corporation is Mid-Atlantic Healthcare LLC, which is a management company used by MHC to provide financial, accounting, tax, and human resource and legal functions to the facilities owned by MAHC. This would be a 40,000 square foot, 66-bed, 2-story addition, as well as a cosmetic renovation for 2 of the other 4 wings in the facility. Prior to MAHC's acquisition of the facility, the other 2 wings had been renovated by the previous owner. The 66-bed addition is will have a special focus on short-term rehabilitation and providing care in a less costly settings under the brand Restore Health. So that is the aspiration of the bulk of that 66-bed addition. The project is estimated to cost $10.2 million, would be paid for with almost $3 million in cash and a mortgage loan of $7.3 million. Looking at the state health plan considerations that I would call to your attention, one of them is facility occupancy, and our standard calls for a facility that is going to add beds to have had a 90% occupancy for the previous 24 months. This facility just misses that at about 88.2%. However, the standard does have sort of an escape valve where an applicant has the ability to make the case why that threshold should not apply. The applicant has pointed out that there was a 30-day moratorium on admissions. During that period, there was a 30-day moratorium on admissions during a flu outbreak. They also pointed to the lack of private rooms and the lack of private bathrooms as reasons that it may have been difficult to meet that 90% threshold. Staff is recommending that the Commission find that the facility occupancy rule should not apply in this review for those reasons. In terms of Medicaid participation, Northampton does not currently have an MOU. It was basically constructed before that condition was in the state health plan. But they do commit to executing one, and currently they have a pretty healthy Medicaid mix with about 65% of patient days being Medicaid. Going forward, at the maturity of the project, they're projecting that that would be 61 to 62%. The requirement in Frederick, the current requirement in Frederick is 37.8%. Looking at the need for the facility, the state health plan does project a need for 66 beds by 2016, and the project would fulfill that. The occupancy rates in the county are just shy of 90% as well, so it's a moderately healthy occupancy rate countywide. Looking at the availability of cost-effective alternatives, there were no other applications filed to meet this need, and the applicant did consider alternatives including total replacement of the facility as well as a total renovation, and deemed that both of those would not be as cost-effective as the option that they have presented. Looking at the viability, the resources to implement the project appear to be there. There's a letter in the file from a CPA attesting to that firm's review of MAHC's financial position and their opinion that MAHC does have the ability to provide the down payment as well as the financial strength and reputation to obtain the mortgage financing. In addition, the applicant pointed out that MAHC has been involved in financing multiple acquisitions and construction projects over the last 5 years. Looking at the ability to sustain the project financially, the applicant made reasonable assumptions on payer mix and occupancy and projects a positive bottom line in year 2. We asked them to show us a Medicaid mix that was a little bit higher than the one that they presented in the application, and while the margins were not as healthy in that scenario, it still was well above break even. It appears that impact on other providers would be likely to be minimal. This is in line with the bed need projection, and thus a 6.1% increase in the bed inventory should not have any undue negative impact on existing providers. The project will improve the facilities at Northampton for the current residents as well as for future patients requiring nursing home care. And in terms of impact on the health system, if the business plan proposed by the applicant, again, attempting to be able to get people out of the hospital sooner and into a rehab environment, if indeed it is able to lower the total cost of care, then the project would also have a positive impact on the overall health system costs. Compliance with conditions of previous certificates of need, MAHC was approved for a certificate of need a couple of years ago for a facility in Charles County. That certificate of need was replaced by another one when the seller of the original property failed to make certain stormwater improvements. That project was completed on time and on budget and met all conditions.
Staff concludes that the proposed project complies with the applicable state health plan standards and criteria, and recommends approval of the applicant's request with 2 conditions. First, that these are basically standard conditions with a nursing home application. First, that they execute the memorandum of understanding with the Maryland Medical Assistance Program, committing to maintain the minimum proportion of Medicaid patient days required by the nursing home, by the standard in the state health plan. And secondly, that Northampton Manor shall meet and maintain the minimum proportion of Medicaid patient days required by that same nursing home standard. With us today for the applicant is George Watson, who is the Vice President for Corporate Development, and Peter Parvis, who is counsel to the applicant.
Perfect. Can I get a motion to approve the certificate of need? Second? Yeah, second. All right. Any questions? Okay. Questions or comments? Fran?
Thank you, Mr. Chair. Thank you, Kevin. Thank you, Kevin.
Not thank you, the microphone. I can hand you the microphone.
I got it. Thank you, Kevin.
I heard you.
Analysis in your presentation. I do have a couple questions on particularly how this 66-bed nursing home proposal will fit into the larger healthcare system, particularly in the Frederick area. In your analysis, there are a number of references to how these beds will have a higher level of skilled nursing care, will accept a higher level of, or more critical level of patients, that it will serve in some part as a substitute for acute care. So along those lines, I have a couple of questions. I don't know if that would be directed to you or perhaps to the applicant or perhaps
Probably most apt for the applicant to join me up here for that.
Thank you. So thank you, gentlemen. I think what our commission, as well as our sister commissions and the state of Maryland, is kind of grappling with is getting our arms around something called the total cost of care. And so we no longer look in stovepipes. And so while we are looking just at this application, there's a number of references in this application to the anticipation that this will be kind of a different kind of facility. It will not be your traditional nursing home. It will have a faster turnover. It will have more acute patients. There will be more rehab in and out. And it will be a substitute for some patients, perhaps all 66, for what currently would be care delivered in the Frederick area to in an acute care hospital. Is that a correct understanding of the new 66 beds?
So to be clear, part of this population we already serve within our facility. So roughly, these short-term type of rehab patients, we run a census of call it between 30 and 40 currently within the facility. So what our plan is to take those 30 or 40, bring them over into the separate unit, which is really dedicated to shorter stay, short-term rehab, where it's discharged from the hospital, provide the type of rehab services that they need to get them back into the community. What we have found, and what we have found in our Waldorf facility, is that when you provide a separate focused area where you bring most of these types of patients together and they have a common goal, as opposed to mixing potentially sometimes with your long-term care population, that it provides a better sense of care, it provides a better environment for the patients. And so that's the vision for this wing. So the wing will have a separate rehab gym that'll be dedicated.
In the older facility, will you backfill then with the
Yeah,
more traditional?
exactly.
So you got about 30, you got an expansion of about 30 kind of traditional nursing home patients, the capacity in the old unit.
That is exactly the plan.
And you'll have about another 35, 36 available capacity for the higher
The
level.
long-term care population,
Okay.
You got it,
Got it.
exactly.
Okay.
Exactly.
So, okay, that's helpful. So does that, how
how is it going to work between you and the hospital?
Sure.
How is that going to work?
We have one quick thing, and George can expand on it. Mid-Atlantic is not a, it is in fact a group, it's a system. It doesn't have a central home office, and they operate in Pennsylvania. In Pennsylvania, unlike Maryland, you can actually run programs and arrangements under CMMI approved structures that allow you to do this sort of thing, and in fact, Mid-Atlantic does that in Pennsylvania. George, want to provide details?
Sure.
And we want to do
Well,
that.
I understand the Pennsylvania, we're unique from Pennsylvania, there's
Right.
differences. But this application is anticipating, putting out together projections for the facility there in Frederick. So how do you anticipate the relationship between you and Frederick Hospital, which is now under a global payment? They've got about, 300 beds there. And so it seems to me that some of your beds will substitute for some of their future patients. So
Sure.
Are you working with them in terms of?
So we currently do, absolutely. So we have a discharge relationship with Frederick Memorial Hospital, and we are what we believe we will allow to do and enhance what we already do is in terms of total cost of care. One is to be able to get some of these patients out of the hospital faster into a lower cost rehab bed sooner. Secondly, we have a great history across our platform, both within Northampton and across our entire platform in terms of lowering readmissions. So come to our facility. We run readmission rates in this facility roughly around 10%, which is well below the state average, about 20-25%. So they come to our facilities. We're not readmitting back to the hospital, which thereby lowers the total cost of care.
Well, it does if there's, I say this, it lowers the total cost of care if there's a commensurate reduction in the budget over there at the hospital. Right. I understand what you're doing, and it's certainly consistent with providing the most effective care in the most efficient setting. But it won't lower the total cost of care unless there's an offset for the care that's happening in your bed with the care that is being paid for in the local budget.
But bear in mind, under this system, a hospital that gets the readmission within 30 days, they don't get paid for it. There's no payment for what they call potentially avoidable utilization. So the concept by your sister agency over there, is that the hospital's burden is to eliminate potentially avoidable utilization, and then they can use that money until they take it away eventually in order to do more population-based health care. So it's not a direct, you're right, it's not a direct dollar for dollar reduction, but by producing revenue at the hospital level, particularly in a case like Frederick, where there's only one, then that frees up the funding for it to do more population-based assistance among the physician level. So that's why we think it does reduce, not a dollar for dollar reduction, but certainly when you talk about eliminating 30-day readmission, providing care to patients who might otherwise have to go in the observation level on a short-term basis for rehab, it's cheaper done here. And yes, the hospital doesn't then give that money up, but what it's supposed to do in every instance is then use that money for its population health initiative. So that's why we believe it would make a significant beneficial impact.
I appreciate that. It certainly seems like we're on that trajectory, but we're very early in the pathway, and how it will be implemented is yet to be detailed. So I have one final question, and that is, that's on the revenue projection on the table on page 23. Compares the first table, that would be table 3.7. Compares the revenues, expenses, and profits. This is down at the bottom there. Compares the new unit with the entire facility as a whole over 3 years of operation. Are you listening there? The table revenues, expenses, and profits, and then below it are the 4 lines which detail gross revenue, net revenue, expense, and then income, which I presume is the same thing as profit. And so my question is, there's pretty much of a difference there in terms of out years. Go to year 3 when you're fully operational. The per bed, per day profit from the new facility, the new unit, will be roughly $50 a day, as opposed to the overall facility at about 24. So can you...
Sure. So there's 2 factors at play. One is because of the disproportionate share as we have allocated into the new 66 beds. Those are the payer mix in the new facility is primarily where we're capturing a lot of our Medicare revenue, and so those typically are more where there's more profit generated. There's more, and so then the entire facility matches then our long-term care population and the short-term stay population. The second piece of the puzzle is that there are certain fixed expenses that are getting allocated across the entire facility that aren't necessarily being shown in that new wing because, for example, we don't have to add a new administrator. We don't have to add new certain different staff positions. So there's the incremental value of these extra beds is what you see here. So they carry a higher margin per bed.
I think I see the Medicare mix in the new facility in year 3 is 38% as opposed to the entire blended facility is 28. So your admissions that yeah, I see that. But you're still going to, you meet the standard as far as Medicaid participation, the test. I've forgotten what the number is for Frederick County, but overall, the facility will then meet it, although this new unit may not meet it.
If the new unit is part of the overall facility, will more than meet the projection need.
Yeah, if you look at that, it's 50%, the number is 41. The other thing is, what sort of alluded to, is a single Medicaid admission to the length of stay is equal to around a little more than 12 Medicare admissions, because they're very low length stay they're using to project. So there are a lot more Medicare admissions churning through here, and quite frankly, if you do it well, Medicare pays more, obviously, than Medicaid does. Very, very different patient mix. So that's part of it. But even on its own, it would probably meet certainly as a whole, we're well over the 50%.
Yeah, I think we, in terms of patient days, we projected to stabilize at a little over 60%.
It's an innovative model. I'll say that. Thank you.
So I have new to the commission and looking through these, there is something I understand, and I think this is a good proposal, but just highlighting moving forward. I have a red flag that comes up when I see that there is no comment from the community about this proposal. And that just, raises red flags. Does that mean you don't talk to the community? I have a hard time believing that. Why not? And in the future, I think there's value to that, because I think the needs of the community can be communicated to us through this system, this process.
Absolutely have had discussions with the community. We've had discussions with the mayor, with local legislators, with the hospital itself. In the future, we will absolutely, that's a fair comment, and we'd be more than happy to provide that. I know in another one of our applications where we thought that there was probably more questions around the bed need and about the model, we made sure to do that. And, that the community has been very favorable for this. I think the addition of more private rooms with private bathrooms as a new option into the community has been met very favorably. But point taken, and we'll keep that in mind moving forward. Thank you.
Did you come under some kind of agreement with Frederick Hospital under their GBR? So I would understand this model be perfect. It's kind of like instead of a physician extender, you have a hospital extender. And to go to Commissioner Phillips' concern, these patients would ordinarily stay in a hospital at higher cost. They're going to lesser cost area.
Right.
And that's what we need. My hospital, personally, we need more of that. But are you, again, going back to the initial question, are you under the GBR with Frederick Hospital?
No, the facility is reimbursed under skilled nursing reimbursements, which would be under the Medicaid plan, managed care, and the Medicare plan. We do have some arrangements with Frederick Memorial where we will do some observation where they might transfer over some patients. It's typically a low volume, but it's typically no, we're not under the GBR. We're under separate reimbursement. The GBR is focused specifically in on the hospital.
And on that point, Pennsylvania, which obviously there are different rules all the way around, but there they do have arrangements, both with hospitals and with Medicare HMOs, MA plans, that allow them to basically take risks where they've been successful. And you can't really do that yet in Maryland.
Well, it's not our purview to do that in this commission, but maybe the ACRC can.
And
to that.
we're actively working to try and bring those sorts of, we're more than happy to accept those kinds of risks. We do that as we set up in Pennsylvania. We can do it on some of our managed care. We do case rate contracts up in the Philadelphia market where we'll have a set reimbursement for the amount of days that set for what a set procedure might be, and we take the risk for that.
It would make a lot of sense to have that kind of arrangement. Secondly, all these additional 6 beds, where are you going to find qualified nurses to take care of these?
So, that is a constant challenge, obviously, within our industry. What we've found is that we've had a pretty good record of being able to recruit them out of Northampton. We don't use any contract nursing.
Do you have RNs, LPNs? What do you use?
We have RNs, LPNs, and then GNAs.
Is there a requirement of how many RNs at a particular time?
There are requirements in terms of the number of nursing hours PPD per patient day that you have to provide, and then that funnels into your rating on the 5-star scale for CMS.
Yeah, obviously we need those.
Right, absolutely.
Meet and exceed those.
Right.
So I think the applicant is correct. Generally, the bundled care for performance improvement, the bundle payment under Medicare, has been slow to take root. It's probably not quite true that it can't be done. It's just done infrequently. I'm only aware of one facility, a Genesis operation in Easton that has a PCI bundled payment initiative with the skilled nursing facility taking the lead, if you will, here in Maryland. But I think there is opportunity to do that, probably opportunity with some persistence on the part of the nursing home, as well as aligning with what a hospital is willing to do under this arrangement too.
So you believe it can be done if parties work at it?
I think that's right, and I think I was going to offer that the staff can provide some information on the progress Genesis has made in Easton, because it's been in place for a while.
We're actively trying to develop these kinds of programs within the construct of the GBR. We firmly believe that that's the appropriate model going forward, and part of the reason for this is we built the timing over which it takes to construct a new wing gives us the time to then go and try and develop out these kinds of agreements so that we can bring those online, hopefully through work with the HSCRC and with all the appropriate authorities, so that we can potentially have those kinds of programs in place.
And with whatever the new model is, when this thing comes online, which will be under the new model in 2019. We appreciate that issue, but part of it also is that you got to have the right facility. So you need you need all the services that we're going to build here. And I don't have any doubt that they will be actively exploring that opportunity. Now is a little bit early since we don't have the facility to do it.
We are, yeah. Thank you very much. Really appreciate it. Thank you very much.
The staff has been very, very cooperative and helpful in this as well. We'd like to thank them.
Thank Thank you, Mr. Chairman, and good afternoon, Commissioners. The Home Health Agency chapter of the State Health Plan provides the regulatory framework for incorporating quality metrics in review. Can you hear me? Okay, thank you. This one's not working. It's working. So in review of certificate of need applications for both establishment of new home health agencies as well as expansion of existing ones, premised on creating more competitive markets and more consumer choice of quality providers. In developing the chapter, staff worked with the home care industry and other stakeholders as part of an advisory group. And at those meetings, discussion included consideration of the quality measures publicly reported on the CMS Compare websites to be used in the CON review process. Recognizing that quality measures are evolving, the Home Health Agency chapter is designed to allow for flexibility in selecting quality measures and performance thresholds for a given review cycle. Pursuant to the regulations, staff posted a public notice for comment on draft quality measures and performance requirements for use in the first round of review cycles. And you have received a copy of the public notice along with the background paper, which provides more detail and documentation. A wide net was cast to obtain feedback from the home care industry as well as from the hospital and nursing home industries. No comments were received during the public comment period, which ended September 22nd. As described in the public notice, there are 3 ways in which the approved quality metrics are to be used in the CON review process: determining jurisdictional need, qualifying an applicant for inclusion in a review cycle, and determining preference, if necessary, among competing applicants. For today's meeting, Carol Kritzmeyer with Kritzmeyer Consulting will present the rationale for selection of the quality measures as well as the recommended performance levels to be achieved. Following the presentation, staff will request that the Commission approve the recommended quality measures and performance thresholds for the upcoming CON review schedule. Carol?
Thank you, Kathy. Thank you. I will start with the rationale for selecting the measures. I get it. No, back. Whoops. Oh, now we're. There we go. One more. Okay, thank you. These are discussed in detail in the background paper, but briefly from this slide, they represent frequently occurring conditions seen among HHA patients. They're required to be collected as part of patient assessment using standardized instruments. The NQF endorsement validates their suitability not just as measures, but also for public report. And they allow for comparisons among providers with sufficient variability to differentiate. That is, they're not topped out, but they're not overly stringent. And these and nearly identical measures are used to evaluate payment incentive programs for a variety of healthcare providers. And specific measures where Maryland scores are lower relative to neighboring states provide an opportunity for improvement in those measures. How would the home health agencies qualify? First, in order to qualify, they would need both an experience of care summary star rating of 3 stars or better and a quality of care summary star rating of 3.5 or better. The 3.0 and 3.5 are the average Maryland HHA ratings for the most recent 3 years of data. Next, to qualify on the individual process and outcome measures, 6 of the 11 proposed quality of care measures and 3 of the 5 experience of care measures must meet or exceed the Maryland average score. By posting these measures both in the public comment period and also when the CON review schedule is posted, the HHA have knowledge of the criteria MHCC expects to be met before an application is made. And this is expected to streamline the CON process, which in the past could have been quite lengthy. In the next few slides, which have already gone ahead, I'm going to list the specific quality of care measures and the experience of care measures.
this slide shows them, there are 11 recommended quality of care measures. During the time period that we're considering, there were a total of 22 healthcare measures reported on Home Health Compare. Of those, we selected 11. The two that are not bolded, taking drugs correctly by mouth and ED use without hospitalization, are not part of the STAR summary rating. The others are indicated by the stars and are. The home health quality of care measures, those that make up the summary STAR rating are the first 4, and communication between providers and patients, care given in a professional way, and team discussed medications, pain, and safety are composite measures consisting of several questions each. The overall rating and the likelihood to recommend are not composite measures. They are single questions. So the summary STAR rating consists of the 4 that are above, and the 5 measures which we are using are the 4 and the likelihood to recommend. The next 2 slides show additional information about the 11 quality of care measures. I'm going to go through this fairly quickly. It is in the background paper, but the summary STAR rating is indicated, risk adjustment, the source of the data, the NQF measure number, and whether the measures used in the home health value-based purchasing model demonstration. And this demonstration started in January of 2016. Maryland HHA are participating in the demonstration. These are the rest of the 11 quality of care measures. So after applying the criteria for the STAR ratings, the QOC and the EOC, and the individual measures, 6 out of 11 and 3 of 5, 21 Maryland HHA qualify. How would non-HHA applicants qualify? Hospitals must achieve equal to or better than 3.0 STAR summary ratings. And the STAR summary rating currently consists of the 11 HCAHPS questions. Some of those are composites, and some of them are single questions. 27 Maryland hospitals qualify using these criteria. Nursing homes must achieve equal to or better than 3.0 on the STAR summary rating. And the nursing home STAR summary is somewhat different. It's composed of health inspections, staffing criteria, quality measures, 16 of the 22 measures that were posted on Nursing Home Compare, and an overall summary STAR rating. 121 Maryland nursing homes of 228 qualify using these criteria. And finally, residential service agencies do not have standardized measures as home health care and nursing home and hospitals. So they must demonstrate accreditation through a state-recognized deeming authority, which requires establishment of a quality assurance program, including collection of data. And we ask that residential service agencies submit certain data as part of their application. So in summary, this is a new approach. It enhances consumer choice of quality providers. It's very transparent. It IDs quality providers by stating explicit measures and thresholds, and we believe will streamline the process. And overall, we think that it will build in improvement in care for HHA patients in Maryland as scores improve. Kathy has some additional information.
So, in accordance with the chapter and as described in the public notice, 15 jurisdictions qualify as having a need for additional home health agency services. And as shown on this slide, these are the 4 multi-jurisdictional regions to be used in the upcoming CON review cycle.
At this time, staff is requesting that the Commission approve the recommended quality measures and performance thresholds to be used for the 2017 CON review schedule of proposed home health agency projects. At this time, Carol and I would be glad to respond to any questions.
Can I get a motion to approve these measures and performance thresholds first? Second. All right. Let's open it up for questions and comments.
Well, this question makes sense, but since we're imposing quality ratings, why were there no comments?
It
seems like somebody usually comments.
That's a good thing. We had discussions through our advisory group. We had several meetings, and actually we got their guidance to make suggestions on which types of measures should be selected. So when we put it out there for everybody, and there was, no one commented.
We discussed these very measures and these types of thresholds with the advisory group, and there were some measures that they made convincing arguments that perhaps shouldn't be included that we were initially proposing, and so we feel that because there were no comments, they were accepting of our recommendation.
Just curious. Home health areas where overutilization and questionable utilization has always been a debate, and how to did that come up to any of the quality measures? I mean,
Overutilization? You mean,
meaning that they're indefinite stays of home health.
Well, this approach is actually, this new approach from the home health agency chapter moves away from looking at volume and looking more towards value. But we did have some discussion, but I don't recall anything being that didn't come up. Okay.
They've introduced some new quality for home health care very recently, so they're not in this data set that have to do with recent hospital stay and rehospitalization, and so over time that will that looks across the continuum of care and maybe of some use.
Hold on, let's just go around and then we'll come back to you.
Thank you. This may be it is maybe an incoherent question, but you said in one of the last slides, as far as new applicants, new home health applicants, 27 hospitals would qualify using on the patient experience metric.
So that's based on all the criteria. The stars, the two-star ratings, and
I believe it said hospital or
hospital, right? 27.
So, our hospital, are we talking about the same patient experience survey that the hospitals report overall their patients in all of their service lines?
When I talk about
because they're not doing well collectively, our Maryland hospitals, and yet 27 of our hospitals would qualify
using
it
is the HCAHPS, which is the hospital CAHPS survey that we are using. We're measuring hospitals against hospital measures
against each other or against
each other.
Yeah, against each other in Maryland.
The calculation is done by CMS and it's done nationally. So it's our rating.
So are we measured against all the hospitals in the country, not just those in Maryland?
Mm-hmm. But the 3.0 that we selected is the average Maryland rating.
I just want to make sure we're not falling into the trap that HSCRC found themselves in.
Yeah.
Is the denominator Maryland hospital or Maryland home health agency performance, or is it the national standard?
The STAR summary rating is calculated by CMS, and they use national data to do that.
But maybe to give the full context for Commissioner Phillips, in a unrelated meeting at HSCRC yesterday, there was just a discussion about how majority majority of the Maryland hospitals were not meeting the national standards on HCAHPS. So that's sort of a contradictory statement. So we're just trying to reconcile facts.
And was that in relation to the experience of care or the quality of care?
Experience. It was related to
Well,
HCAHPS.
Okay. In fact, I believe it was reported we were the 49th of the 50 states.
So could I ask that you go back and just double check and
Yes.
get back to us on that?
I can do that.
That would be terrific.
Thank you.
Keep going this way, Diane.
So I don't think it's a good thing that there were no comments. I'll just be really blunt about it. And even if you've got organizations who gave a lot of input, providing comments to acknowledge the input and their support is helpful, because it's hard to know how to interpret silence. Silence could be disengagement. Silence could be that they missed the public notice, that frankly a 16-page public notice was too long, depending on who was reading it. So anyway, I start with that. I would hope that our goal is to always get input and in the public comments, and always get input not only from the entities that were mentioned as far as industry members, but also input from consumers. So I'm interested to know what was done, if anything, to try to get some review and input from the public notice from consumers.
Well, I can just, there was consumer representation on the advisory group, and I remember that her first response was, I never even knew there were these compare websites. So we really were educating her, and she was like, wow. So it's kind of, we realized that many consumers don't know that these compare websites published by CMS publicly or even out there. So when you say to try and get it from consumers, we take up advertising. I mean, it's out there, but there's so much that we feel as staff we can do. I agree with you. I think like a month while we were working on the public comments, and we worked with the trade associations, and we spoke about how they were going to help us put it on their public server, and I spoke to other agencies directly to let them know. I had conversation over the phone to please look out for this, but nobody chose to respond. So I mean, I felt the staff did due diligence. I don't know if you have a specific recommendation what else we could do.
We sent emails.
We sent emails out. We did
HHA organizations, both local and nationally.
Right. So I have a second question. I do think that it would behoove the commission generally to have a set of organizations, if nothing else, if it's not reaching out to the broad general public, but a set of organizations who do represent the public perspective that we could go to regularly to get input really from a consumer or a patient or a family member perspective, just like we go to industry groups. And I'm happy to help identify some of those organizations and individuals, and to really make it a priority to get some public input from those who are looking at this from a consumer patient perspective. Curious to know what you see as the practical impact of this. So thinking about those organizations that fall below average, because those are the only ones who aren't in the categories that you've identified, what practical impact will these regulations have? What effect on them?
Well, at the public notice, or just generally this approach?
Generally the approach.
Okay.
I've moved away from
what we're hoping for is that home health agencies will improve in quality. Because what we're trying to show, as Carol mentioned, is a transparent process. They see, if I want to expand my authorization to serve, I have to beef up my quality. I know what I have to do. I need to be better than my peers if I want to go from a 2.5 to 2.5 star to a 3. And we think that's part of a change in mindset. I think we're just beginning. As Carol and I've noted, these measures are just like starting out to really be out there. The value-based purchasing model that's here in Maryland is going to take effect in another year and a half, and it hits their pocketbook in 2018. So all of these things are happening, but we want to, as staff, to provide an opportunity now.
That's wonderful. And so creating those incentives for improvement, awesome. That's really great. If they don't improve, what's the practical impact?
If they don't improve, then they won't have the opportunity to expand their authority.
If they will be denied a certificate of need?
That's correct. They will not be qualified. And how Carol mentioned about streamlining, and I know that Paul has mentioned in earlier commission meetings, we're basing a lot of this on our past experience in doing certificate of need review for home health agencies. Some of these applicants come in, want to be, but have no clue what it takes to become a Medicare certified home health agency. So this is saying we're going to put out the qualifying factors. When they see that they have to be a 3 on a star rating, what does that mean, star rating? They're going to go back and realize, oh, there's something called OASIS. I know I have to hire coders. I know I have to hire the appropriate staff, have to work with a specific software vendor that's required by Medicare. All of this is going to start sinking in the potential applicant's mind, and that they're not going to come to us without having first thought that out well. So we want good providers, want good applicants, so we're not wasting their time or our time. We want them to be successful businesses. We don't want to hold them back, but we want to make it clear to them what it is that they have to do. And that's the approach that we're taking.
Home health has been around for a long time. I think it's done a great job. Since CMS came out with the buzzword of readmissions and so forth, I've personally seen development of other agencies on the Eastern Shore. Shore Wellness Program, for one. There's other home ports. There's some telemedicine projects developing. Is there any coordination among this care? And you seem to all have the same goal in mind, but I don't see any communication. It's like the CIA and the FBI not communicating. Is there any project to coordinate all these efforts? Because they all come under, ones I just mentioned, under GBR. So I just want to know if there's any coordination or effort to coordinate these
home-based type.
Yeah, there's several different ones, and one seems to morph into the other one. It gets a little confusing as to who's doing what and who's talking to who. And
I agree, it is confusing. A lot of it is by the name itself, the label name. In Maryland, we have different types of licensed entities providing different types of home care services. This commission, this authority, as by our statute, is only responsible to regulate through our certificate program only one type of license entry, and that's the home health agency license. Given that said, we do look for, there are a lot of home health agencies that also have other types of home care licensed providers. Like there are several home health agencies that also have residential service agency license. And I see that they do coordinate between themselves. But I think your question is broader, and I think it's a very appropriate one because we all are looking broader now with a wider lens and wider perspective. I think that part of our CON review standards will be looking at linkages and what else they are doing within their service area, what else they will be doing. I think that's a very good point.
Areas where they have telemedicine in the patient's home. But it's very patchy. I don't know if it's just experimental, but with all the technology we have, you'd think you'd be able to coordinate a little bit better.
That's a very good point. Thank you.
How do these ratings apply? And I looked in the regulation, I didn't see it. How do these apply to a truly new entity?
How do we apply for?
If a truly new entity is applying for a certificate of need, do they have a period of time to come up with star ratings or?
Okay. I can clarify. I think I can clarify this. It is confusing. In the regulation, we allow for certain types of applicants to apply. We have the existing Medicare certified home health agency, so it's an existing entity, and they are going to be expanding their operations, and they're going to be expanding under their Medicare provider number. So they don't have to have any startup time waiting to first get Medicare certification. The other types are the non-Maryland home health agencies, who are a home health agency that's existing in another state. That's another type of applicant, so they should have more quicker startup time. The third type, which is what we talked about here also, are the non-home health agency applicants. And we're allowing for hospitals and nursing homes who are good quality providers as a hospital to come in to establish a home health agency program. So the star rating is not as a home health agency. The star rating is as a hospital. Because you're right, they wouldn't have that opportunity because they don't have the star rating for a home health agency. Does that make sense? Does that clarify?
Sure, but so what I'm hearing is that if I wanted to go into the home health business, I'd actually have to go to another state, start a home health agency, and then come back in order to apply for a home.
Well, if you are an RSA providing skilled nursing services, and RSA is a Maryland license only, it's not like, that is another opportunity, another channel, another avenue that you can come in.
Question around innovators in the market. You ever heard of a company called Buurtzorg?
Buurtzorg?
Buurtzorg. It's a Netherlands company, and if I can digress for 2 minutes, it's a pretty interesting company, just because I think it shows the kind of innovation that can happen in this area. Because the CEO of one of the services companies, he came and visited yesterday, and it was founded by an entrepreneur in the Netherlands with the notion that nurses need to have self-managed teams, and that you really need to build on the holistic patient relationship. A long story short, took a company from 0 to 15,000 nurses now in 40 countries, self-managed teams, and with 15,000 people, he has an admin staff of 30. And no hierarchy, no multiple layers of organization, and unbelievable outcomes certified by KPMG. And so this is sort of a global thing that's happening in Europe and happening now in Asia. And it just shows the power of innovation when you can kind of get it. And so I just think that we need to be thoughtful as we're thinking about the reg to not stop innovators from getting into the market, because the only way we're going to solve the total cost of care issue is for us to allow innovators to get in. And so, on some of these things, I feel like we probably need to approve the measures, but in the past, what we've done when we try to get a dialogue between the commission and staff is to at least propose some issues and then come back at least in the updates or during lunch or what have you. And I would just ask that maybe the HCAP, engaging the stakeholders and the innovator questions sort of, those are not easy answers to get to, but I think it's worthwhile to take some of the feedback and see where we can get to.
And I think that across our state health plans, we're beginning to think about how we use those plans to further innovation broadly, nursing home health, hospice in particular, perhaps some additional flexibility in ambulatory surgery as well. I think those are all good points. Historically, there's been a heavy weight paid on experience, and I think to the point today where we are, we have to think of ways in which innovative programs have a way to get a foothold, be they through pilots, which are at least under traditional CON oversight, doesn't fit well, but we're seeing a lot of ideas come forward as a result of the global payment model in terms of new types of providers wanting to fit into the new delivery system. And I think that my hope is we can go forward with this, but come back to you and talk about the adaptive changes that we would make to provide for that type of innovation, be it through pilots, which, as I said, are hard under CON, but some sort of way to further, if you will, a very credible startup that can demonstrate, that seems likely to offer innovation and improve satisfaction and quality in a particular domain. There's a question that Dr. O'Connor raised. I think we're at a point where there is long-standing recognition that the healthcare system generally, and certainly in Maryland, is extremely high siloed. And as a result of the hospitals going on a total cost of care model, they've hired their care coordinators. Mr. Sargent has his care coordinators. There's been various incentive programs for primary care practices to hire their care coordinators. And I think one of the hopes for the outgrowth of the next proposal that will go to CMS this January is that the state can lay out a plan by which there's greater integration of care so it's really a loaded term, but I think greater ability for patients to use care efficiently and greater ability of the system to deliver it economically. And I hate to say this, but it is we'll have to wait and see how we put that together over the next several months. The plan that will be put in place, proposed to CMS, will not be a built-out plan, but rather, I guess I would characterize it as a skeleton going forward, in which we explain how these different categories of care are better integrated under a consistent convening concept of the total cost of care. I think we have missed the boat a bit by failing to recognize that the total cost of care can be a convening concept for lots of different providers, but it has to be explained, and they have to consult how they can help in that domain. Otherwise, it doesn't fit.
Yes. I'd just like to ask you a question to kind of link the last two questions. So the kind of innovative shop, not even another state, another country, given, and then back to Commissioner Sargent's comment, would they be able to compete in the state of Maryland right now if they were coming in kind of without any particular prior track record in the state and wouldn't have these sorts of scores, et cetera, et cetera?
No, they would not be able to come in right now. They have to meet one of these types of applicants. And part of it we're discussing before Commissioner Stolenwork is the fact that our statute requires only CON for the home health agency license. There are other types of licenses that maybe would be more appropriate for startups to begin with, maybe as an RSA, before you become Medicare certified and have to meet all the conditions of participation. When you realize what is required by CMS, some of the folks who have good hearts and souls and want to be a provider of home care, people in the home, when I start to tell them what's required of them, like, oh, I don't want to do that. And that's the history is part of why the RSA license was created, because it's not able to be Medicare certified. It's a license only in Maryland. So when I hear about these passionate people who are calling, we do have to get out of the silos. Maybe we need to begin to restructuring the way we license home care service. But is that the role of this commission?
Right. And you can understand because of the fraud in the past why the hurdles, CMS would take the kind of action they've taken. But yeah, thank you.
Bob, is that?
Yeah. Thank you once again. I was looking at the need determination on page 10 of your notice, and you have three criteria: insufficient consumer choice, the first one, highly concentrated service market, and the reference there is to the Herfindahl-Hirschman Index, which is kind of standard. We all know what that is. And then, of course, you have the insufficient choice of HHAs with high quality performance. When I was reading this, I take it that to get in the door for a CON, you'd only have to meet one of those. Is that correct?
Correct.
Okay, I want to make sure. Good. All right, I want to make sure. The other thing, though, that I noticed with this, with regard to need, it says, consistent with these regulations, insufficient consumer choice is considered to exist in any jurisdiction in which consumers have 2 or fewer Medicare certified HHAs that serve 10 or more clients each year during the most recent 3-year period, et cetera. This goes back to the conversations we had earlier about the 3-year period and all that business. I mean, I very frankly, what troubles me about this is that we're establishing as the criteria for entry, a duopoly. If you wanted to expand, opportunities for people in Maryland to have home health, you certainly wouldn't establish those standards. I know that, we've got a whole long tradition in this area and all that, but I just got to tell you, that just, frankly turns me off. And, I would imagine that as medical technology advances and we are looking more and more to trying to save on medical costs, that home health agencies and what what Craig Tanio pointed out earlier is they've had a serious problem in the past. I used to deal with the Medicare stuff, morning, noon, and night. I know all about the fraud problems in the past and all that sort of thing. But, really, I mean, what I would like to see the commission do is try to expand opportunities as much as possible rather than constrict them. And I just got to tell you, this particular restriction on this needs restriction, I frankly think is a problem.
Well, may I respond?
Sure.
A couple of quick things. That particular criterion was because in our prior plan, we had that opportunity like that for an agency that was in a contiguous jurisdiction that had fewer than 2 agencies to be able to expand without there being a need defined. So we just put it in as to further bridge the old plan to the current plan. The second criterion, which talked about the competition index, the market concentration index.
Yeah.
When you look at how many of those jurisdictions, it opens it up. So we just wanted to build upon something that we had before. So we feel that by having those 3 criteria in place has many more opportunities than our last plan chapter.
Okay, so you're telling me that this is actually a liberalization of the rules.
Yeah.
All right. Okay.
And these regulations
I'll take what I can get,
adopted,
Kathy.
but we talked about, okay, fair enough. Thank you.
Take what I can get. Is Dr. O'Grady happy with that?
Perhaps I'm still reacting a little bit to the past history of home health agencies and the massive fraud when the door was completely open. That I can live with a little bit of gatekeeping here, as long as it's not just guaranteeing the same people, a captured audience without innovation.
Okay. Other questions or comments? If not, let's move to a vote to approve the quality measures and performance thresholds for the CON reviews in the home health agency application. All in favor? Aye. Any opposed or abstentions? Okay, this is approved. And then if I could just note that the 3 areas of discussion about HCAP, engaging stakeholders, and how to address sort of innovators, we can sort of keep in some open dialogue that we'll get back to in updates or another way to the commission.
Thank you very much. Thank you, Commissioner.
Thank you. Moving on to agenda item number 8, around the 2016 pre-authorization benchmark attainment report. Maryland law requires the MHCC to work with payers and the PBMs to implement an electronic pre-authorization process in a series of 4 benchmarks. In the past, the PBM has been the real sticking point in this process, and Justine Springer, program manager, is going to present the key findings of this report. Tell us if anything's changed.
Sure. Thank you, Chairman Tanio and commissioners. So for the span of about 2 years, the state-regulated payers and pharmacy benefit managers, or PBMs, implemented 4 benchmarks to successfully introduce and support the electronic pre-authorization. The payers and PBMs collaborated with providers in the design testing of the benchmark. I mentioned for pharmaceuticals, we've seen some minimal growth in the use of the online portals. However, for medical, we've seen much more substantial growth over the past 4 years. And more work is needed by payers and PBMs to maximize the benefit of technology for themselves and for providers. So in 2012, Maryland was one of the first states to enact a law that mandated electronic pre-authorization. The goal of this was to create administrative efficiencies in the pre-authorization process. The MHCC worked with the payers and PBMs in the implementation of the 4 benchmarks and is required to report annually to the governor and the General Assembly on the attainment of these benchmarks. And this is the last legislative report as required by law. So the 4 benchmarks allowed for a phased approach for the payers and PBMs to implement electronic pre-authorization. First, they were to provide an online listing of all the medical and pharmaceuticals that required pre-authorization, then the development of an online system that could process pre-authorization electronically and a way to track pre-authorization requests, then a way to establish if all pre-authorizations for medical and pharmaceuticals were being processed within established timeframes. And lastly, there is the implementation of an electronic process to override step therapy and fail first protocols, which was in line with the requirements for paper-based methods. Our key findings in the report found that the largest payers and PBMs attained all 4 benchmarks and have implemented online portals to process pre-authorizations. For medical, the use of these online portals has grown by about 60% in the past 4 years. Growth for pharmaceuticals has been more minimal, with less than 6% in the same time period. Online portal use for pharmaceuticals is not likely to increase, and this is due to standalone online portals being outside of a provider's electronic prescribing workflow. So EHR vendors have developed applications that are able to be integrated into the e-prescribing workflow, thereby eliminating the need for the provider to leave their workflow to complete a pre-authorization. Since this is the final legislative report, we wanted to provide a look ahead as to where the industry is in terms of pre-authorizations. So under emerging alternative care delivery models, requirements for pre-authorizations are likely to continue. Alternative care delivery models focus on improving care quality and health outcomes. This requires a shift in the traditional way that providers, payers, and PBMs work collaboratively. These models also focus on technology, and through the use of technology, payers and PBMs are able to apply more automation to the pre-authorization process. Payer and PBM education and awareness activities related to the availability of their online portals is expected to continue. And as more EHR vendors begin to incorporate standards that support a more direct payer PBM communication, we are likely to see a shift of use of the portals to favor these other technologies that are able to be integrated with the EHRs. Thank you, and I can take any questions.
Great. Questions or comments?
Medical and pharmaceuticals, correct?
Yeah.
Residential is not correct.
Medical and pharmaceuticals.
And how long has it been in effect?
Since 2012. 4 years.
Yeah. And what is the consumer role?
You mean healthcare consumer? So,
is it visible to the consumer or not?
So, if I may, so that's an interesting question, but it's really an application. The short answer is it should be invisible to the consumer. If the electronic process works as it's moving forward, it's seamless. So it occurs from the physician's application and runs right down to the payer and then to the pharmacy concurrently. Today, the use of portals was really a stopgap measure, if you think about it, because as technology evolves, it fills that gap. But the legislation was supposed to fill a void where the technology standards weren't yet adopted to allow that kind of seamless integration. So the use of portals will eventually shrink, and probably, I think we've seen the plateauing of them, frankly, on the medical side, and the pharmaceutical piece is never likely to grow. But if it works well, it should be invisible to the consumers, to tell you the truth.
David, do you see that like Open API will sort of address any of this? Because what everybody wants is people to go on their system, and what the physician and the staff want is to just kind of work with their own workflow and not have to jump on everybody's system.
It's a great idea.
Answer to our tech problem?
Sure. So it is not an open API structure yet. today as it moves between the applications that exist for e-prescribing. They're more structured. They use a specific defined NCCDP 5.0 script standard. So it doesn't allow a lot of flexibility. As technology emerges, and maybe this is too much into the geek side, but as FHIR, a new standard emerges for APIs, it's inevitable that the industry is going to shift more towards an API, an application program interface, where developers can create their own way of getting data back and forth. 5 years from now, probably in the short term, it's pretty limited to standard systems.
So we're still in the paint phase.
Yeah.
Other questions? Okay. No, thank you very much.
Thank you.
Thank you. Yeah. While we're on the technology theme, we're going to talk about cybersecurity. Cybersecurity threats are increasing. In the last 2 years, both CareFirst and MedStar have been victims of cyber attacks. And MHCC, through its authority to promote health information technology, brought the healthcare industry together to discuss common strategies and best practices for combating cybersecurity threats. Staff conducted a cybersecurity assessment of the Maryland acute care hospitals in the spring of 2016, inquiring about hospitals' efforts in preparing for and managing cybersecurity risks. And Nikki Medusky will present the key findings from this assessment.
Thank you. Good afternoon, Commissioner. The threat of cyber attacks is growing in healthcare, and this is happening as they become increasingly dependent on electronic systems to manage patient medical records and perform other administrative tasks. Maryland hospitals are making efforts to strengthen their cybersecurity strategies to guard against threats such as ransomware. Ransomware, the rise in ransomware in particular, is a primary concern for hospitals today. This involves malware where hospital networks are held hostage in exchange for money. Typically happens through a phishing scam where if they click a faulty email or link in their email. Because of this and the evolving threats, hospitals need to continue to build cybersecurity into their existing governance, risk management, and business continuity plans. And with this, employee awareness and education about cybersecurity is one of the best defense. With malware, we find 9 times out of 10 it starts with human interaction. To just kind of give you some perspective on how hospitals approach cybersecurity, their ability to plan, design, and implement effective cybersecurity controls are critical in preparing for and managing these emerging threats. It's a shared responsibility requiring a wide-ranging view of people, processes, and technologies to understand potential vulnerabilities and areas for remediation. This is done typically by conducting a security risk assessment, which identifies critical cyber assets. And these are the electronic devices and communication networks that are essential to operation. Conducting a security risk assessment is a key component of HIPAA and required by the federal program, EHR Essential Program. Just a snapshot of what's happening nationally. Cyber attacks are estimated to have increased 125% since 2010. They're now the leading cause of data breaches, and in the past 2 years, about 94% of hospitals have experienced a data breach. In regards to ransomware, victims of ransomware have paid $209 million in the first quarter of this year, as compared to $25 million in all of 2015. The impact of a cyber attack can result in loss of data and patient privacy, disruption to operations, financial losses, and reputational harm. Just a little bit about the assessment before I present the findings. It was conducted this past spring. All acute care hospitals participated. Hospital CIOs and CISOs self-reported data through an online questionnaire, which inquired about their efforts to prepare for and manage cyber risks, and the results here are presented in aggregate. We inquired about cyber maturity among hospitals. Cyber maturity being their ability to protect critical assets and adequately detect and respond to a cyber incident. Almost all hospitals report making at least moderate improvements over the past 2 years. and cybersecurity programs in health systems, which are often viewed as being more robust because they have more resources. But nearly one-half of community-based hospitals report making substantial improvements over the past 2 years. All hospitals. Yeah. The hospitals deploy a variety of activities to assess risk. This allows hospitals to plan appropriate protocols. Nearly all hospitals in a health system conduct more than one security risk assessment annually. And more than half of all hospitals also report plans to modify their emergency preparedness and incident response plans, enhance their policies around cybersecurity, and test some cyber incident response plans. With liability insurance, with more widespread adoption of health IT, hospitals are taking a closer look at this. Cyber liability insurance is an essential part of risk management, providing protections against the cost of a breach, loss of data, or ransomware incident. About a half of hospitals report plans to modify their cyber liability insurance coverage. With vulnerability scanning, hospitals do conduct these scans at varying degrees of frequency. Scanning enables them to identify gaps in their security gaps in their network. And typically common vulnerabilities include unpatched software or use of default or weak passwords. Hospitals conduct these scans on at least an annual basis. And HIPAA does not require scanning specifically, but it is a key part of a first step in a security risk assessment. With penetration, penetration testing, they are performing that on about an annual basis as well. Pen testing is basically the output of your scanning and attempts to exploit a vulnerability identified, usually with a knock hacker. Several hospitals do note plans to increase their pen testing frequency. Taking a closer look at incident response planning, the majority of health systems have developed a cyber incident response plan. Most plans at community-based hospitals are still under development. Key components of an incident response plan include people, processes, and technology extending beyond IT and into other areas such as human resources, legal, marketing. Many hospitals did report initiatives to continually assess opportunities to build upon these plans. And lastly, establishing a security-minded culture helps reduce the risk of a cyber attack. Hospitals are deploying a number of activities to increase awareness. This includes formal training on cybersecurity, reminder notices to employees, and conducting cybersecurity campaigns. Looking forward, we're planning to use these findings to help increase awareness about cybersecurity. We're trying to explore opportunities with stakeholders to develop peer learning forums and webinars on cybersecurity. And we're also working with hospitals to finalize the cybersecurity self-assessment resource guide. So I'm happy to take any questions.
Let me start. It seems like this is really great information. So I might push you to be a little bit more, I don't know, provocative or bold in the conclusion. So do you have a sense of what best practice would really be here? Because you did put a stake in the ground as to what the best practice would be. Like, we needed two-factor authentication, and we really need to be able to do weekly scans. Maybe 80% of the hospital industry is not in there. I don't know if that's the best practice. You know, but I'd love to kind of get that sense, and this may be one of those things where best practice is pretty controversial, so it's hard to kind of put that. But I'd love the commission to get a feel for, you know, how big is the risk, because it looks like it's definitely there, and then the question is, the headline is how big is it?
So it is an amazingly fast-moving target. 2 years ago, what constitutes best practices were sometimes doing annual assessments among the community hospitals. The larger academics tended to do them, biannually. Now everyone is moving in the direction of monthly, and some organizations are looking at them daily. I don't think we have yet a benchmark of best practices around cybersecurity because it is such an area of vulnerability that not only does it happen within this country, these attacks happen external, and which makes it even more difficult to track down when they're overseas. So the hospitals in Maryland are doing a yeoman's job of sort of rushing to fill the hole because in technology, everything happens so much faster than the policy, and then people sort of backfill on the policy piece. But unfortunately, we have yet to hit what's the best practice. Although, I will say, if you look at it from a breach standpoint, while there are a lot of attacks against hospitals that happen in any organization almost daily, there's a lot of sort of attacks on the system. Only one breach has there been that we can recall in, or maybe two. One happened this year, and I can think of another one that happened in a few years back. So it's well contained, and the responses tend to be very quick. Paying ransom is not what the best method for resolving it is, but hospitals nationally a lot of times do that.
And can you educate us around the two agenda items earlier? We were pushing physician practices to get electronic health records, but most of those are cloud-based software. What's the view there? I saw in the notes it sort of says that more than 50% of the claims are for the small practices, so I'm kind of concluding that whatever it looks like for hospitals, the physician practices are probably even higher risk of just getting their data hacked. But is that a valid conclusion or not?
So they were, up to this point, they were an unknown source of information. But they are indeed a target, but anyone who uses technology is for all intents and purposes, a target. We haven't seen a lot of hacking at the individual practice level because what hackers tend to do is they're looking for big sources of information in order to sell the data, in order to offer ransom. If you're choosing a small practice, the likelihood of a solo practitioner being able to pay ransom for that data to be unlocked is small. It still happens, though. But the other thing I would say is because we've moved away from client servers in practices and more to cloud-based, the protections are much better in the cloud than they really are managed at a local site.
So I kind of have a unique perspective on this, and I like to recognize that this month is Cybersecurity Month, and it is something that people didn't know about. Not yet.
You get in a Christmas
I know the idea of checking on an annual basis is completely unheard of in the industry because you just don't have the time. You know, just think about our iPhones or the amount of updates that you get. Anytime you get an update, there's a reason why you're getting the update, and you should heed it and download it. And education is one of the biggest things, educating the users of it, but also the people who are the consumers putting their information to the hospital. And I think that's my biggest thing to highlight here. Do the hospitals need to have all the information about us that they have? Is it really required to have all of those numbers or the background information? Because the more information you put out there, the more can be taken and used. So what do they really need and in order to do their job? And that's what they need to protect. If you have too much information out there, it's harder to protect a lot of it. So just put that out there.
So is for discussion, or is that sort of? So when I think about the information hospitals collect, they didn't start out asking too much. Over the years, they asked for a little information. A lot of it was related to in order to ensure that a claim gets paid. Then they started expanding it to collect clinical information that can now be shared and used for population health purposes. So I think what we're seeing is actually a move to growing information that hospitals have, as opposed to trying to contain it or in some way limit that. But I've not heard hospitals say they ask for information that they don't think is important to a need that they have. But yeah, they collect a lot of data, but so are financial institutions and
Yeah, it can make you nervous at times.
Well, I'll give you an example. So most practices collect Social Security numbers because they should. But then when you actually unpack that, there really isn't much reason to, and when you do the insurance company, so I think some are realizing they just should stop the nature of.
Or your driver's license number. What does that have to do with going to a hospital?
Yeah, who's going to pay?
That's for on the reimbursement, for collection piece. So, but yes, you're right. And I think that's a good takeaway for us. We will, as we talk to hospitals, we'll bring that up as an area that we can begin to have discussions about, and we look to see if there's ways we can start people thinking about containing or maybe reducing some of the asks, if you will. Very good point. Just a quick aside, as someone who is not for a long time actually put their real Social Security number down, every claim gets paid, even though it's just, you know.
Oh, I've had the option.
In the last 10 years?
Oh, yes, very seriously so. It's, you know, if the claimant's denied, nobody tells why, and then you go through back and forth for months, and then it turns out that somehow the hospital or the care provider, whoever it was, in my case it's always been a hospital, has transposed two of the numbers in my social, and the insurance company said, bingo, we were denied. And there it was.
I'm pretty sure my insurance company doesn't have my social
They shouldn't
either.
be using your social.
Yeah,
to
right.
claim it.
Okay. Well, the more substantive questions that I had to do with, well, this is also clearly a law enforcement question. And so I wondered what kind of coordination, is there a work group, is there something with the Attorney General or who we think of as law enforcement in the state? To actually, because, I mean, there's two things. Certainly I was also struck by what do you mean you do it annually? That seems just woefully inadequate. And then the notion is, and the only people who are really testing your vulnerability are people you've hired. So is there a need for an outside, you know, kind of attempt to see how secure these systems really are, that they don't get, you know, a 2-week warning that it's coming, you know, that sort of thing. And that, again, seemed to dovetail more with what's the Attorney General doing on this. This is clearly, you know, it's a healthcare question, but it's also a pretty serious law enforcement question.
Yeah, and the symposium, cybersecurity symposium that we convened in collaboration with the Maryland Hospital Association, Maryland Chapter of HIMSS, and the Health Services Cost Review Commission in early September, we brought this to light. We had Daniel Gray, I believe. He's an FBI agent. He came and spoke about the law enforcement angle and the work that's going on in the state. He also manages from the FBI level a listserv that hospitals we participate in. So whenever there's national alerts, we get them, everyone, the hospitals, they get them ahead of time so they can begin to be aware of these things. The Attorney General, I've seen some blips and blurbs about some of the cybersecurity work that's underway. I haven't followed it on the law enforcement end all that strong. But as it relates to your audit question, most hospitals have in fact, I can't think of any that doesn't use an independent third party to do hacking and penetration testing. That, I think, fell by the wayside years ago. It would be a mistake for anyone to say, well, we just tested internally. They tested internally, but then they retest it using external hacking teams, if you will, controlled hacking exercises.
Well, I guess one question would be, does the Commission feel that this is enough to take it up to a level where there would be sort of a reach out to the Attorney General for a coordinated policy approach on both the law enforcement and the healthcare concerns involved in cybersecurity? Because I understand that the hospitals, and they'll do what they can, and they'll take out the insurance. I'm feeling more for the person who, you know, while the ransom is being negotiated, their operation goes south. You know, the fact that they have enough money in their insurance policy to cover a later suit. I mean, I don't mean to be hard on the hospital, but there's this other thing. Prevention would be very good in this area rather than chasing, you know, a perp after the fact in a more traditional law enforcement. But I guess that's one of my questions. You know, does the Commission want to do more than simply note what's going on and try and, you know, take it to the level it's already been taken? The other question is, in terms of, I was taken by Chairman Tenio's point about what's best practice here. And you're right about some of this stuff goes slowly, but at the same time, some of us sit on other advisory commissions with the Fed that look at some of these sorts of issues. If this is something that is a HIPAA-related, there certainly is an agency at HHS that is, from its history, more of an enforcement agency than your typical sort of let's pay people or let's approve drugs or whatever. We have the Office for Civil Rights. And is there a need for that kind? Do we, as representing the state of Maryland in this case, want to push for something that looks like some sort of a federal, what is best practice in this area that we could then, hopefully be able to apply in a Maryland situation? Is that, because that's sort of, without having to go to Congress, without having to have legislation, that notion of recommendation to the Secretary of HHS that HIPAA enforcement needs to pivot, expand, whatever, to help cover these sorts of concerns.
So I certainly yield to you all in the direction, but I think Dr. Moffett was going to make a remark, so I would yield to.
Well, no, actually, I was just going to follow up on what O'Grady is saying. The biggest, to my knowledge, the largest cybersecurity attack that was successful was a direct attack against the United States Office of Personnel Management. And my understanding is several million people, as much as 20 million people, may have been compromised. We're talking about personnel records. The damage there, of course, is incalculable because a lot of those records also include classified information related to background investigations on people that are held by the Office of Personnel Management. OPM is basically the #1 line of defense for the country in terms of, not strangely enough, not the FBI or DOD, but the Office of Personnel Management's #1 line of defense when it comes to background investigations for sensitive positions in the federal government. Anyway, I'm sure that because of the horror of what they've gone through, the estimate, the calculation is, the belief is that this was a Chinese communist attack, that there is a lot of interest and talent, at OPM trying to figure out how to prevent this from happening. And I am certain, I could actually help you make, because I used to work there, make whatever, introductions there are just to get us in there to talk with them, to find out what they're doing. Because they have been under tremendous pressure by not only the Obama administration, but also the Congress to basically try to prevent this thing from happening again. Exactly, sure.
That would actually be outstanding, because I think what we see in cybersecurity is it's evolving quick, and everyone's trying to backfill. And maybe best practices continue to emerge as some of the things we learn. One of the notables that Nikki mentioned is that we're trying to help the hospitals figure out what the best practice tool, getting everyone to develop or participate in developing this resource using the NIST framework. And I think, would that serve as a default best practice standard? Maybe not, but it certainly provides a good shell for how best practices will emerge. They will emerge, but I think to your point, Dr. Grady, we need to push this along faster, and with some guidance and some help from others at the commission, Dr. Moffitt's introduction, we can begin to work in these areas more carefully.
Can you, I was about to mention the framework. Can you define what the NIST framework is?
So the NIST framework is very big. The National Institute of Standards Technology, they have many series. They go hundreds of series. And what we're looking at, they define specifically a standard around cybersecurity. They have different modules. It looks at identify, protect, and there's a couple other pieces in there, and they're escaping me, but they're complex. They're a complex series of rules that NIST has developed, and you can use that, organizations use that as a way to structure best practices, if you will, for them.
Right.
But NIST doesn't say, here's the best practice industry-wide. It says, here's a framework, and we think everyone should pull from it.
And that's what my comment was going to be, is I don't know that it would make any sense for us as a commission to develop the level of expertise needed to specify some kind of security protocol. But there are things like the NIST framework are efforts to develop that you can use in contracts, like with the other side and say, well, your security protocols will follow this framework to comply with, where you don't have to get into the details as much as to figure out that they're following the same framework of analysis. That may be more something to be thinking about rather than.
Well, and I was thinking also, when you're thinking about how do you move policy, and so how do you do this? So if there's a HIPAA connection, the notion that the HIPAA enforcement agency is sort of, if there's some need for a discussion, that if they're also comfortable with NIST, then that might be very helpful in terms of getting actual implementation to happen. If they say that part of what we consider under HIPAA compliance is, have you met these kind of, we're not saying this is the only way you can do it, but it's not uncommon in federal policymaking anyway to say you can do it any way you want as long as it meets the general criteria. But here are 2 or 3 models you can use, safe harbors, that if you use that, you're effectively guaranteed that you'll be in compliance because, and that's where I would see sort of a role for a NIST standard that says you do that. But it would be very helpful if you're going to go back to providers to be able to say, this is not just we picked one as, state of Maryland. This is what the feds are already saying is sort of will, if not guarantee, take you a long way to the road to HIPAA compliance in this area if you're willing to do what is that best practice that Craig was looking for. But I don't know whether they're there yet. I don't know whether those feds do it. I do know that you don't have to go through the full rulemaking given in this area, as we've seen with other things in health IT and the use of, of the different protocols and whatnot that required a faster, more facile movement.
And something else to say, to recognize about the hospitals in the state is the strong CIO community here. It is amazingly adept at modifying for change quickly and communicating with each other. It isn't in CIOs and chief security information officers, they don't compete on data or best practices. So the peer learning opportunity in Maryland is fairly strong.
And their history is, there's been very visible data breach. Rivers to mind, the MedSub data breach that made national news a year and a half ago.
Yeah.
But I think working with, there's only so much the commission can do. Remember, our budget is pretty limited. It wouldn't, I think, highlighting these issues. I think there are some things that are important, but I think carrying this forward is done best with collaboration. I think the Attorney General, as well as the State Office of Homeland Security, have important roles to play, and probably we need to be sure that they are not moving forward in parallel. Working with them is very important. I just note that Ty O'Connor from the AG's office here today, her major focus is on consumer issues, but I'm sure she can be an entree point for putting us in the right contact with the AG. But the State Department of Maryland Office of Homeland Security is also an entity that I think would be very much engaged in this, and we want to be sure that we don't take on things that other people are working on as well. I did want to also just observe that I think that Commissioner Phillips knows, is well aware of this, that the hunger for data is going to grow by significant magnitudes as a result of activities anticipated in the next version of the Maryland model, with particularly approaches like population health or geographic models in which hospitals would take responsibility for patients in their geographic service areas, whether those patients had recent or even immediate access to that hospital. And if those models move forward, hospitals would have a significant need for information for folks that might not be closely linked to those organizations, which I think are going to raise a lot of concerns, and I think those are clearly much more in our responsibility area. Number one, as we play a role in these models, but two, have had a long-standing interest in patient privacy.
David, what has been what is the plan to syndicate this within the state and the stakeholders in the government and outside?
So we're just embarking on that pathway. This is our first year where we've taken more of a deeper plunge into cybersecurity, as well as most organizations. It's been sort of pulling all the stakeholders through. We're using this information to go back to the hospitals to help to begin to define what the framework for best practices will look like. But to, I think, someone's point earlier, the resources, the information, the resource guide that's coming out of this work will be extremely valuable to smaller organizations, nursing homes, physician's office, you mentioned earlier dental practice. So what we see is the tools that are beginning to emerge from this work will have an enormous valuable trickle-down effect in other places in Maryland. And we really want to focus on the quiet group that we're not hearing about in our nursing homes in here today. As they embark on more technology, the risks are great. And you can say the same with physician practices, ambulatory surgical centers, et cetera.
Yeah, so I think if you go back a page, I guess I would just ask that you try to synthesize some of the feedback from the commission and translate to make that into a more robust next step. So I think there was a piece about just, can there be a better assessment of best practices? Not that you're developing them from scratch, but just kind of looking at stakeholders, engaging others in the state government, and then seeing if there's ways to, with other stakeholders to increase the awareness. Because I think this is really a commendable job at doing what we do well, which is to get a lot of the stakeholders together and start to frame the issue. And I think you're hearing from the commission, there's a lot of interest in building that momentum while realizing that there's restrictions and resources.
Indeed. Thank you for that feedback.
And I agree with Dr. O'Grady about this issue should be in the purview of this commission, since we're charged with health and information technology here. Enhancing it, I think we should also make a statement, either standalone or with the Attorney General, about best practices. I think it comes under our purview to do that.
Yeah. I was just going to say that the same way that Dr. Moffitt offered to help with OPM, I'm happy to help with HHS in terms of the National Committee on Health and Vital Statistics. If that's of any help.
That would be excellent. We'll reach out to you as well. Thank you, Dr. Grady.
Thanks, David.
Thank you.
Ben, overview of upcoming initiatives.
We will have a commission meeting in November, and we expect, as I mentioned, as we start, that we would bring our freestanding medical facility regulations forward. I think we will have to make a determination whether they would be modified and brought forward as draft proposed regulations, or if the changes that Department of Legislative Services has recommended would constitute non-substantive changes. And then we would release them as final proposed regulations. We'll be informing you as we move forward. We'll also be reporting on the status of the Maryland Physician Trauma Fund. That's a fund that the Commission administers, and recently we've seen some decreased use of uncompensated care as more people are insured, and so we're seeing a growing fund balance that we'll talk a little bit about. We'll have several CON applications, and as is our practice, we don't necessarily flag which ones they will be, because there are issues typically that can crop up, but we expect to have several. And then lastly, as is our tradition in November, Linda's team will present the data submission manual for the all-payer claims database for 2017. That we need to share that with the submitters prior to the start of the year.
Before we adjourn, I'm still decompressing from the Prince George's saga. But I think I would be remiss if I didn't state for the record the absolutely outstanding work of the commission staff, specifically Kevin McDonald, Nicole Parker, Joel Ricklin, Boy Sue, and our wonderful attorneys who've given me wonderful advice all through this process and kept me out of trouble. Sue Ellen Weidman and Siobhan Madison. I think from the standpoint of professionalism and dedication and hard work, the staff of this commission is a model of the civil service. I just had to say that, and I want that on the record.
Thanks, Bob. If there's no further business before the commission, I'll entertain a motion to adjourn. Second? Meeting adjourned.